AAZPIRE 2024 workshop. And this morning, it gives me great pleasure to introduce Dr. Shankar Viswanathan, who agreed to deliver this talk on novel methods in cancer research. Dr. Viswanathan is an associate professor in the Department of Epidemiology and Population Health at the Albert Einstein College of Medicine, New York. His areas of interest include multivariate survival analysis, longitudinal data analysis, observer agreement, missing data analysis, clinical trials, global health, injury epidemiology, obesity, oncology, health disparities, and food insecurity. So he has vast experience in the field of biostatistics, and I hope you will derive a lot of benefit from listening to this talk. Thank you very much, Dr. Viswanathan. The stage is yours. You may start your talk now. Thank you.
Thank you. Good morning, everyone. And good morning, Dr. Koda, for the invitation and introduction. And thank you. Appreciate it. Today, I just going to talk about this next 30 minutes or so. We're going to talk about phase 1-2 design. So before going into it, so 2010, the NCA, National Cancer Institute, Clinical Trial Design Task Force for Investigation Drug Steering Committee came up with a report where it said, like, the community, there are a couple of quotes I put in. The community has failed to embrace novel, more efficient trial designs. Because that time, more and more cancer research was, especially the phase 1, phase 2, were more using the conventional designs, 3+3 designs. Especially when the molecularly targeted agents or immunotherapy agents were coming on during the period, and still upcoming newer drugs are coming up, older design doesn't work. So they came up with a recommendation, basically saying both traditional 3+3 designs and novel designs are acceptable, and newer designs should be used. But when they came in, in the last decade or so, after this report came out, have been quite a development, and a lot of innovative designs have come up. So that's what I'm going to put. It's not a comprehensive list I'm going to cover, but to a certain extent, I'm going to talk about phase 1 designs and phase 2 designs, phase 1-2 designs. Today's the talk I plan to do is the first couple of minutes. I'll talk about algorithmic designs, which is 3+3. So the single agent designs are late onset toxicity happening with cytotoxic drugs. So under which I'm going to talk about model-based design as well, and model-assisted designs. And once we complete that, then I'll go into a little bit of phase 1-2 designs. Again, I'll address some of the issues. What type of designs can be used? So that's where I'm going to start. And if you have any questions, just stop me. Okay. So traditionally, phase 1 clinical trials started with cytotoxic drugs, where the objective of the phase 1 trials were to find maximum tolerated dose. Here there is a chart where I put in. The blue line represents if you see that, that's what usually for the cytotoxic drugs, where the objective looked at like that. The assumption was the toxicity as well as efficacy monotonically increasing. What I mean by that is basically when the dosage increases, the efficacy also increases. Okay, the efficacy on the right side and the toxicity on the left side. So parallelly along with the toxicity. So we normally have a drug to be a certain target level as an acceptable limit, that we call it as a maximum acceptable toxicity. So under that circumstances, where it comes to the dose 3, according here, there are 5 doses for it. Dose 3 reaches the maximum tolerated dose. and provides the maximum efficacy. So that was the idea which was there before. So under this, there were many designs that were developed. So there were three types of phase one designs. You can group them, which we call it as algorithmic designs, which is a common A plus B design, you can say. The commonest one in the example could be 3 plus 3, which are, these designs are transparent and easy to implement. You don't need any statistician to work on. So you have a lot, it's based on logic. The second type of designs which came up was to improve the algorithmic design, were model-based, which was first proposed in 1990, and subsequently there were a lot of variations. I'll talk about a couple of them. These designs have superior performance, but less transparent in a sense, like it's not explicitly written. The backend everything runs on a model, and you need statistician help or statistical help every time you allocate a dose. So it's logistically a little bit complicated. The third design, which is more recent, I would say, is started during 2015, I would say. So I would say 2008, that was the first model-assisted design I can think of. And slowly, as more recently, there are more designs. This is a hybrid. You can think about it. Uses model for efficient decision making, but also combines the algorithms to provide you decisions, so that you don't have to do any complex things. So the decisions are given ahead of time before you start the trial. It has superior performances, as well as it is easy to do. We'll see some of those designs one by one. Okay, so all these designs, most of them were developed by a statistical group. There are a lot of teams work. So I wanted to point out most of these designs which I'm going to talk today, you can go to this MD Anderson website, and they have a R Shiny package based design, and you can conduct the design also over there. I just wanted to show you that if we have time, then I can show you some examples on the website itself. Before we go into, so first let's start with so the simplest one, and most of you are aware of this, might be aware of this, is a 3 plus 3 design. 3 plus 3 design, what it does is, so basically you start with starting dose or a starting cohort of 3. You add 3 patients at a lowest dose. If they have no DLT, go to the higher dose. The decision is, if you have 1 DLT, then you add 3 more patients to the same dosage level and see how much it is. If there are no DLT, then go to the higher dose. If additional among the 3 new cohort, you have 1, 2, or 3, then you reduce the patients. Okay, go back to the previous dose and do it. If there are no back doses or no de-escalating doses available, you stop there. On the other hand, you have 2 or 3 doses in the first cohort, 2 or 3 DLTs occur, MTD is exceeded, you stop the study. So this is the simplest of the designs which you can pick up. But the problem is, people have pointed out and have come up with a lot of studies, a lot of papers presenting that 3 plus 3 designs have a poor operating characteristics. One of them is poor accuracy to identify MTD. The problem is, like, if 1 by 3, like the studies have, so 1 out of 3. So either we are saying 0 out of 3, 1 out of 3, and 2 out of 3. So one out of 3, then we can increase it. So normally we have 33%. So the target toxicity is normally 33%, we are keeping it. But on an average, when you calculate it, it comes to only 25%. If the interval is, if you are working on, the MTD level is 22%. So it doesn't, normally if your target toxicity is not up to 30%, On the other hand, instead it is 20%, it's not good. Okay, so it doesn't work. The 3+3 design doesn't work. Secondly, the 3+3 design has high tendency to underdose patients. So a lot of times what happens is you are putting more patient to a lower dose, which is not efficient. So that's the second case. The third one is the target specific DLT. You cannot pinpoint. If I want to have a 5% target toxicity or 10% target toxicity, you cannot deal with this design. So that's one of the drawbacks. The fourth point is basically when a cohort deviates from 3 or 6, it is difficult to make decisions. What I mean by that is usually what happens is like you have you recruit 3 patients, okay, and the cohort in the middle of the observation period, one of the patient is non-evaluable and they drop out of the study. Now, how do we deal with this too? How do we calculate our target? Our decision making is going to happen is based on 3 patients. So one idea is to add in 1 patient. We can normally what people do is add in 1 patient. If that 1 patient also is non-evaluable, then this goes away. It's a problem. Instead of that, we can add 2 more patients. Now, what happens is the decision is, so how do we deal with the decision? Whether to increase on what basis? Are we going to deal with the first 3 patients or the second 3 patient? How does it? If one of them become DLT, and already this person is DLT, 2 out of 4, which is 50%. So which is over the target toxicity rate of 33%, which is 1 by 3. So it's very difficult to work with whenever the cohort deviates. Okay, so it's hard to make any decision based on this design. The second other problem is usually when you are following up with a cohort expansion. Study recommended dose based on the recommended dose, selected dose from the phase 1 3+3 design. We normally do a cohort expansion and you do 3 more cases, the same thing, right? So you have 6 patients if you do that, and you have 3 more patients, and let's say that this patient, okay, so I'm just going to get rid of, okay, so 6 more. You have 6 patients, 1 out of 6. The 7th patient has a, let me get back, 1 second. You have second patient as a DLT. Okay, so this is the cohort expansion. What happens? You have recommended this dose. The first 2 cases on the cohort expansion becomes toxic DLT as DLT. Should you consider? Should you continue with the dose expansion? There is no decision for that. There is no way. Should we consider or should we continue to go ahead based on saying, hey, only 3 out of 9 now is toxic, which is like 33%. Is this okay? Or should we take only the last 6 patients? There is no failure. So there's always a problem. So given this consideration, people have come up with a newer design, which are model based. So the first design which was proposed was on the continual reassessment method. This has been in existence, and there are newer variations of designs have been proposed. It's called modified CRM. So under this is a model based design. It has a base, and first design when Quigley proposed it, and Quigley and Fisher proposed it. It was like it has a frequentist as well as a Bayesian model, but it had some dose escalation issues overdose control was a problem. So people later come up with adjustment for those overdose escalation without any overdose. So to give an idea, I just wanted to start with. So usually what we have for the CRM is the number of doses. Normally when somebody comes to me and say, hey, I want to do a phase 1 trial, I ask a couple of questions. The first one would be, what is the number of doses are you planning to use in this trial? Okay, so it can be 3 doses, it can be 4 doses, it can be 5 doses. So then I'll say, then the second question is, what are the skeletons? Based on your expertise, can you give me what are your guess that a DLT probability at each of these dose levels, what you're saying? So that will be the PK. And the third question would be, what is your target DLT probability? So what is the acceptable probability level? 20%, 30% usually people keep it. And number of patients treated is depending upon what is the proposed number. So normally people come and ask me is, what's the proper sample size for this? Especially for a cancer clinical trial, not what we give a guideline is it's dose times 6. So it would be a better thing. So if you have 5 dose, 30 is good. If it is 4 dose, you can have 24. It can work. So that's the thing. The rest of them is the number of patients experiencing. These two are the observed values what we put in the patient. So there is a good tutorial that I would refer if you are planning to just read that. It's easy, technical advanced paper in BMC in medical research methodology that gives you a lot of examples. So let's go into how to do it. Usually, so the model-based design, what it does is, once I have the information, what people do is it uses a parametric model, what we call a dose toxicity curve. Either there are many different versions of this dose toxicity curve, but I put only two here. One is called an empirical model or a power model, or the second one is a logistic model, single parameter. There are other log gamma models available, or you can have a 2-parameter logistic model. So as I said, the probabilities which I ask, normally I set up a what we call a skeleton. Usually I ask when people say I have 5 doses. So I ask them at each dose, what do you consider a probability? What is a probability? What do you expect? So we use that as a prior distribution that is coming from a Bayesian perspective. Okay, so when we do that, then we add that, what happens is, so first we fit this model. Okay, I'll show you how I'll give an example. Either it can be a single patient or a cohort of patients. Again, it can be 3 plus. You can have a cohort of 3. So cohort of patients. So with the prior, whatever the investigator provides me the probability, the model will run and update the data based on if the first patient observation period is, if you have grade 3, grade 4 toxicity within 8 weeks, that's or 2 weeks or 3 weeks, maybe that's how the designers you are monitoring. You wait for 2 weeks, you update the patients. Similarly, if you have a cohort, 3 patients put in, you wait until the 3 patients, the 2-week period, or if the observation window is 4 weeks, then you wait until the 4 weeks. Observe everything, how many people got DLT, you feed in the data into the model. Then the model will spit out what will be the next dose. So that's how the model-based data CRM works. So usually what it does is, given, I know this is statistical, this is one of the few slides I put some notation. What it does, it uses a likelihood. So the data, what you have normally when you put the patient into a particular dose, J, that is 3 patients, then how many patients have a DLT under the observation period, that fits into the likelihood function, and it gives you the probability. So based on the probability, what it does is it will tell you what is the next dose. the program will tell you what's the next dose. So that way, keep updating until the last patient is exhausted or last cohort is like complete. Then you take and make a decision based on the characteristics. What is the correct dose or optimal dose? So the model-based designs are usually the CRM-based models have a solid statistical foundation, and it has a superior performance than 3+3. It's very flexible, especially when you see that when you have a patient drop out of the study or non-evaluable, that's not a problem at all because it uses the additional patients. It uses the data from the previous whoever completed data to dictate what the dose should be for the next cohort. So it shouldn't be a problem. So cons of the this model-based technique is when the model is misspecified, performance can be compromised. So one of the problems is to overcome this, people have come up with called Bayesian model averaged CRM. So that is available on the website as well. So you can run that. What it does is it runs different type of models and takes an average out of it and tell you what will be the next dose. So it accounts for the model misspecification. The second con, as I said before, is it needs for every patient or every cohort of patient, you need to go back to the statistician and say, hey, this is my updated data. Can you run the model and give me the next dose? So it works like a black box from the investigator perspective. So there is always like, oh, I do not know how it goes. So there is a thing, but this CRM-based models have been very popular. Here is an example which I put in. It's a combination of lenalidomide and azacitidine. And you can see that they use the empirical dose toxicity model to calculate. The third type of model, what I wanted to point out, is more hybrid type, I would say. It uses an statistical model to come up with an efficient decision, but it will give you dose escalation instead of being a black box. Right away, when you start using this type of design, it will give you a table saying what to do with whether to escalate or de-escalate right ahead of time. Okay, so a couple of them I have listed here. One is called a modified toxicity probability design. So it was proposed 2008 and 2010 it came up. Then it has some disadvantages. People don't recommend, but it has an overdose problem. So I'll talk about it. So it uses a type of probability interval, unit probability mass function. I'm not going to go given the time limitation. So that UPM or a unit probability mass based dose escalation, it's hard to interpret. So we cannot figure out how to do that. So that's one of the biggest problems. The second one is practicality is the high risk of overdosing patients. So it's been like normally people say the DPI was used in the earlier trials. I'm not sure if people are using it nowadays. There is a modification to this. Okay, in 2018 or 20, so there was a modification came up by resolving the issue of overdosing thing, which is called a keyboarding thing. This gives you a really nice, so basically easy. What they did is, so in the UPM, the modified MTPI model, it calculates. An investigator comes to me, I'll ask them what's the proper dosing interval. So investigator has to give me if the target probability is say 20%. So the interval would be 15 to 25% is acceptable. So that will be taken as like, so this line, whatever it is considered as say, for example, if it is 25% target toxicity, it will be taken as 25 to say 30 and 40 here. So this is the UPM upper level and the lower. So this is the proper interval. This is the underdosing interval and the overdosing interval. So it calculates the probability mass, and based on that mass, you make a decision: escalate, stay, or not. So same thing, but slight modification. It has the here in the keyboard interval, it uses the similar concept, but except that it adjusts for uses the equal interval. I'll move on from that when we have time. I'll come back. I wanted to talk about an easier design, which is more and more being used, and it has been FDA has strongly recommended this design for Bayesian optimal interval Bayesian design. It's very easy to use. Normally, investigator has to specify a target DLT level and an under dosing cutoff point of 5.1 and overdosing cutoff point of 5.2. That is also being given by the whoever developed it, Liu and Yuan from MD Anderson. They said, okay, you can take 5.1 to be 0.6 and 1.4. They have done a lot of simulations and say this works on most of the situations. So it's already built in. So so it gives you based on these numbers, they give you escalation data point and de-escalation. All you need to give as an investigator is what is your target toxicity. So once you have this, what you do is you put in 3 patients into a dose, okay, and calculate the probability. Probability is nothing but you have to say how many patients are there, how many people had toxicity. Then it calculates like number of patients divided by, say, if you have 3 patients in, sorry, if you put 3 patients inside the cohort and 1 patient has 33%. If this 33%, the P is less than the lambda E, then you escalate. If, on the other hand, if the probability what you calculated is greater than the lambda D, then you are going to de-escalate. If it stays within the interval, then you stay at the same dose. So it works on a model called a beta binomial posterior distribution model. So, and it corrects for, it minimizes the probability of incorrect decisions of both escalation and de-escalation. So normally what it does is like this Bayesian design, when I'll show you in a minute, like what. So the DLT rate, if you're doing it, start with a pre-specified dose, treat the cohort. If it is the last one, you stop the trial. If not, then look for the values. So usually, if you have a 25%, it gives you an interval ahead of time. If it is 20%, you have to look for what is your calculated probability, number of DLT over the number of patients in the cohort. So if it is less than 0.197, then you are going to escalate it. If it is greater than 0.298, you are going to de-escalate. If it is anything between these two options, you're going to stay in retain the thing, and you keep rotating until your number of patients is exhausted. So this is how the model assisted designs like Bayesian Bayesian design. There are different versions of it. So you can download as a desktop one or launch. These are some of the trial examples, like people have used this Bayesian design. There's a larger list, but I could only cut and paste from that article which they published. Like so it's a very good design being used. Okay, so any questions so far?
Hello, Dr. Vishwanathan, can you hear me?
Yes.
Yeah, I have one question. This is Vikram Gota here. So now, traditionally, 3+3 design has a lot of flaws. So it is recommended that we use more and more model assisted designs. But when it comes to efficacy of the trials, efficiency of trials, as in trying, getting to the DLT or the MTD with the shortest number of people or whatever, have you seen historically any difference in the Boyne designs versus the traditional 3+3 design in terms of trial efficiency? And do you have any?
Yes, of course. So I'm not put, unfortunately, I didn't put that because there are multiple simulation-based papers. People have shown that uh, the model-based as well as model-assisted designs have been far superior to the 3+3 designs. Especially if you're dealing with the number of patients, whatever you're putting in, especially correctly identifying the maximum tolerated dose. So, for example, uh, many a times the 3+3 designs have shown to be underdosing the patients. More patients are put in the lower dose than what they are supposed to be in. While these designs have shown to be correctly picking up the designs much better. So that's the advantages of this. So that patients get the right dose within the target toxicity. So there are many literature available.
Thank you. Any other questions? Okay. Yeah. Come here. Come closer to the mic.
I'm also trying to show you while the questions are going on. So this is the website. Are you seeing the thing I just switched from my slide to? So this is an integrated platform they have. This is really nice. Then you can see that you can choose if you're doing a phase one. It will give you phase one, whatever suite are there, CRM. You can run a keyboard suite or a Boyne. Phase two, you have dose optimization, you have a different one. So they have really done excellent thing. So you can say that. So if I go to a Boyne, so you can launch a Boyne. Usually it runs different. I'll take the question, then I'll show. Yeah.
So, sir, these designs, as you said, so mostly the clinicians would be doing the 3+3 design. So mostly these designs and these trials, they have to be done by the mathematicians, right? I be able to do these designs? I mean.
Yeah, of course. You have to consult. Like certainly, you can do those things. So that's there. You can. I strongly recommend my colleagues to explore. Okay, so that's why I took this one. You can go and read about it. There are a lot of things available, and the software is available. So that's exactly the same side. And but as far as if you have the information, you can play around. And certainly, I encourage everybody to try it. But I will also strongly make sure that you talk to a statistician so that you have the right choice you have chosen or right setup. So before you design a study, but you can certainly do that and you can conduct the study. So I'm going to reduce it so everything in the same screen. Is this? Can you see everything? So if you see this, is it big enough?
Perhaps not. They may require a slightly blown up image because people are
Yeah,
sitting.
just need it. Okay, I'm going to make it to original size. Is this good?
Yeah, this is fine. This is fine. Yes.
So you see the trial setting and the simulation will give you a trial protocol, animation, and select the MTD. You have normally trial protocol. They will this website most of the things they will if you're saying you have a FIDOS, you can type in. So you have starting dose. You can have a starting dose at the lowest dose or middle of the dose. So depending upon so that you have a de-escalation opportunity. You can have a cohort size of 3, then say 30 patients, there are 10 cohorts. You can say that stop the trial. If one of the doses have 12 patients in, you wanted to stop it, you can say that. So this is the default, I'm just telling. So for a particular drug you're testing, you normally have to know what is an acceptable target toxicity probability level. So maximum toxicity that you say is acceptable, that's 25%. These options you can leave it for now. So normally do it, and this is the overdose control. If anybody greater than probability greater than the data is 95%, then you will stop. Okay. So all you need to do is like just go to the table and it will give you how to start. So because the 25% it is based on this, it's a standard value. So it's number of DLT rates. Basically, when you put 3 patients in, all you need to know is how many patients. If 0 out of 3, then it becomes 0. Then you escalate. 0 is less than 0.197. So 1 out of 3, then it is like it's greater than. So then you will de-escalate. Something like that. So it keeps rotating. So decision table also, if you say it also gives you a decision table. If you have first 3 patients you put in, valuable. If you have 0 DLT, okay, then what you do, and if it is 1 DLT, what you do. So if it is 1 happens, then it gives you. If it is 0, excuse me. If it is 0 DLT, then whether to stay, de-escalate, it will give you, and also it will give you opportunity. If you have 3 patients, if you have number of patients with DLT 0, you escalate. If it is 1 out of 3, you stay. 2 out of 3, de-escalate. Okay, so then D is if this is the last dose, then you eliminate. So similarly, you keep increasing based on this. So it's pretty easy to run. Okay, same thing. You can have a different scenarios. Like what if you can ask, what if my scenarios are, what if I chose my dose levels are different, right? So all of them can be higher than 25. All of them, some of them, one dose could be less than 25, but all of them are. So you can add any number of scenarios and run simulations. Okay, so it'll give you operating characteristics, how often, what is the probability that, like, if it is the first scenario, every dose is greater than 25%, then the early stopping of the study is 7.4%. It'll give you the operating characteristics. So you can read through it and see, modify what you think is right or wrong before you start the study. Okay, you can also add in a lot of things. You can also try out simulation. If you're putting in, you can say delays to the start. You can add those numbers in, and you can create. So if I run it, it'll start showing how. See, it will tell me what happens in pre-sub. You can set a scenario, and it will tell you what. So it's really nicely made. So you can check. Going back to the slide. So the model assisted ones are very handy in the sense like you can determine like a 3+3 design, but it has superior efficiency and performance. And that's that. Okay. Going back, sometimes traditional phase 1 studies involving cytotoxic drugs has focused on assuming the RECIST criteria grade 3-4 toxicity within the first cycle. But the problem is some of the molecularly targeted agents or immunotherapy agents has changed the paradigm. Like there is basically, yeah, there is a paper in 2011 by Postal Vinay. They said like more than 50% of the grade 3-4 adverse events were observed after the cycle 1. So you have a late toxicity. So how do we deal with it? So the designs what I showed, the CRM design or a Bayesian design or a 3+3 designs, like they are supposed to be meant for complete data. So you have a patient, you observe DLT, then based on that, you increase. What if you have a late onset of toxicity? Okay, then you have to wait. Well, how do I treat the patient, right? This is also a case with radiochemotherapy or radiotherapy patients. We have observation window is pretty large, but if your approval is faster, okay. So how do we deal with it? Like, shouldn't the patients who are waiting needs to be treated in the right way? So we need to figure out a way. So people have so the problem, like one of the issue with the previous whatever I talked about is there's a logistical issue we can think about. The DLT and efficacy assessment window is pretty long, then it's a problem. Say, for example, you have DLT happens within 8-week observation, okay, and but for that particular disease, cancer, you have one patient per week approval. So if it is 8 weeks, so if you put a cohort of 3 patients inside, okay, so the rest of the patients, so the first 3 patients, first 3 weeks, you need to wait for the third patient to complete the 8 weeks. So that we can add from 3 patients or the 5 patients into the study. So that's not optimal, right? So current time, if you're looking at it, like you don't want patient to be waiting. So so that's what it's here. So patient 1, this is the observation window. It's the current time. If this is the observation window after this, well, how do we deal with these patients? Okay. So how to treat? So one way, an extension of 3+3 design was proposed, and there have been, which is called a rolling 6 design. Skolnick et al. They came up, proposed, and gave a decision. Like similar, they extended up to 6 patients. Okay, so what it does is the approval of up to 6 patients when the DLT for some of the patients are pending. They gave a decision table in that paper and say you can use that. For example, for a cohort of 3 patients with 1 DLT, 1 no DLT, 1 pending DLT, they add 6 more patients and they give a decision for them. Okay, it's very simple and transparent, similar to 3+3 design, but it also carries all the drawbacks of the 3+3 designs. But a lot of pediatric cancers have hematologic cancers have used this rolling 6. There are also model-based designs available. That TIDE CRM, which was proposed in 2000, it's called time to event CRM. It's basically a CRM extended, which uses a partial information of the patients. So the approved patients come in, and whatever the time they contribute are used as a weight, calculate a weighted likelihood, like the CRM, and get the results for what is next. So there are additional variations. People have treated the patients who have not completed the study period as missing data and use that. That's a data augmented CRM. It's under the CRM package, it is available. So here what you need to do is similar to what I mentioned before. Sample size, that is usually 30, you use it. Target toxicity level is 20%, 30%, 35%. DLT observation window needs to be specified clearly. That needs to be, say, if it is 6 months period, so any toxicity within or a combination of toxicity between 6 months or 1 year, we can say that will be considered, has to be specified. What is the observation window that is to be calculated? Then of course we can choose between empirical model or a logistic model. Then using the prior distribution, you use it. Usually what we do is it's exactly like the CRM, but the thing is the first patient up to the observation window, this is the line is T1, but the actual, say it is 1 year, actual observation window is until the last, but you have observed up to this. But the second patient already has a DLT. Okay, so if somebody has a DLT, then their weight is 1. But if this patient 1, if their follow-up time is only up to T1, say the observation period is 12 months, this patient only contributed 3 months. So 3 out of 12 will be the weight. Similarly, a third patient recruited into the study has completed only 1 month, then they contribute, they will use their information, partial information to calculate the weight. That's 1 out of 12 will be their weight. So you use that and use them into the same likelihood before, and you get the dosages approved. So one advantage, one of the how it uses it, the CRM model, any model-based uh, designs, it uses the whole toxicity curve, whole data from all the patients, whatever you have approved so far. And every time a patient come in or a cohort of patients you put in, you have to use the whatever the dosage there and plug it in, run it again, and get the next dose. Okay, so that's how it's done. So I have designed a study which is ongoing. It's a phase 1 fraction stereotactic radiation FSRP study. So we had 5 doses. So in this study, what we did is seven grade. We started in the middle of the dose, so we have a de-escalation option. So this is called the prior. So I asked the investigator what are the toxicity level they consider 2.9%, 5.7%. They think 8 gray would give a 52%. This is the prior distribution. Then we use the scenario, different scenario to calculate. The observation window for this study is 1 year. So we get 2 to 3 patients in the center a year, but if the observation window, we have to wait. So we choose this design, and we can, and we are into like 5-6 years now. About 2/3 of the studies, 30 patients is completed. So we have used. So tight buoyant is another option. It's model assisted. If you're not okay with modeling, then tight buoyant could be another option, like which uses the weight, which also uses the weight. But one good thing about it is it does the same thing as the buoyant, but it gives you a escalation de-escalation tool. Okay, so basically what they do is number of patients you plug in the escalation number and the de-escalation number based on your toxicity. With the late toxicity unknown, they are treated as missing data, so it uses a weighting. We call standardized total follow-up time. Then using that time as a missing information, they will tell you so this is a calculation. Normally you have to make it sum of follow-up time divided by the length of the DLT window among the number of patients. Then you decide if 6 evaluable patients are there, 1 of them observed DLT, 2 pending patients. Then whatever the pending patients number, you calculate the STFT, and if they are less than 0.6, then you stay at the same dose. If they are greater than or equal to 0.6, then you escalate. So same thing. If you are going with, if you have only 3 patients here, 1 had a DLT, 1 pending patient, number of patients pending. Okay, the another one is not have a DLT. So in that case, you calculate the whatever the pending patients number, you plug it in, and here the 8 week. So I'm showing an example of that 2-month window, observation window, and there are 2 patients per month is approved. So you can think about it. You plug it in, and if the value is greater than 0.88, you stay, and if it is less than 0.8, so this table is already fixed and it's given. So you just follow the table and say, hey, if the patient comes in, I check the number, and based on that, you say escalate or de-escalate. It's pretty straightforward. Okay, so this is a tight buoyant. I used that table, created the table based on the ongoing studies decision table. This is the study. This is nivolumab without whatever ipilimumab with the gynecologic cancer. They used the observation window to be 8 weeks. Approval of patients per month is like 2 patients per month. So that means 4 patients in 2 months they are going to come. So the target toxicity was set at 30%, and there were 4 doses. So they used this. Okay. So there are methods available: tight buoyant, tight keyboard design. So you can use whichever is which you think is optimal. Okay. I don't know how much time do I have?
So we have almost utilized the 45 minutes allotted for this talk.
Okay. Then I'll stop it. Then,
Okay. Yeah. Thank you very much.
yeah, if that is okay. Yeah.
I think that should be okay because I think the participants got an idea of how to design phase one trials in oncology, both the rule-based designs as well as the model-based designs, and I think you also touched upon those where late toxicity is not very important, and in those situations where late toxicities are important, and how to design studies for that as well. So I think it is a fairly comprehensive overview of early phase trials in oncology. So I would like to invite participants for any questions that they may have. So while we are waiting for the participants, I have one question, Dr. Viswanathan. So when it comes to first in human dose, so I mean, do you use any modeling to identify the first in human dose, or is it still the traditional method of converting a safe animal dose into a human equivalent dose and then taking adding a safety factor and then arriving at the first in human dose? So what would be your strategy for identifying first in human dose?
Are you asking about the preclinical to clinical?
Yeah, I'm asking about the preclinical to clinical, but
Yeah, it's the same thing. 1/10. It depends upon what type of animal. I think 1/10 they use. It is mice, I think, and if it is
yeah, no, yeah, correct,
different animal,
correct.
it's the same criteria.
So the question was, you don't do any predictive modeling to kind of,
No. I'm not involved in the preclinical stage. I normally deal with
okay,
mostly with the phase one part of it.
okay, okay,
So, but as far as I know, I think still we are using
same.
the same criteria.
So whether it is rule-based or model-based, the same criteria to identify the first in human dose, but only the way the dose escalation happens is different in the two settings.
Yes, yes. So the more and more, I think there are some optimization-based techniques have been used recently, but I'm not familiar with it. So
No, thank you. Anything else? Okay, if there are no more questions, Dr. Viswanathan, thank you very much for this very comprehensive overview of phase one trials in oncology. I mean, it was really a treat to listen to your talk. And thank you very much for being up so late. I'm sure it is past midnight in New York. And I hope to see you more often in our future conferences. Thank you very much.
yeah, thank you for the invitation. And,
Pleasure.
yeah, so I think I sent the slides. I should have been there. Let me know. And I think that there are other things there. People can look at it. And,
Sure.
so yeah, the slides are. I sent to the Gmail account.
Okay, okay. Thank you very much, Dr. Viswanathan.
Have a great day.
Thank you very much. You too. You too. So the next speaker is Dr. Santam Chakraborty. Dr. Santam Chakraborty is a consultant radiation oncologist at Tata Medical Center, Kolkata. He completed his MD in radiotherapy from Postgraduate Institute of Medical Education and Research, Chandigarh, after which he went to Canada for a one-year training in IMRT before settling in Tata Medical Center as a radiation oncologist. And his areas of interest include apart from treating apart from being a radiotherapist, he is also interested in health economics, and today he is going to talk to us about observational study designs. Over to you, Santam.
Great. Thank you. Good morning, Vikram, and good morning, all the participants. Am I clearly audible?
Yes, Santam, very much.
Thank you. Great. So today I've been asked to speak about observational studies, and without further ado, I think most of you who will be present today, going by the abstract that we had reviewed, would be doing some form of observational studies. And observational studies can be divided into two broad groups. You have descriptive studies, which basically involve things like surveys and case reports, we will not be dealing with these studies today. We will be more focused on the analytical observational designs, which involve case control studies and cohort studies. The experimental designs include randomized controlled trials, which will be dealt with later on. So coming to observational study designs, you have the design based upon the observation. So what is a cross-sectional study? A cross-sectional study is where you start the investigation at a particular point of time. You take a group of patients whom you observe and you decide whether they have the outcomes or not. A prospective cohort study starts at a particular point of time whereby you evaluate a cohort of individuals who have exposure to certain risk factor. Now please remember the word exposure and outcome. These will come again and again in these presentations. The word exposure refers to something that causes an outcome or a disease. So to put it simply, smoking causes lung cancer, then smoking is the exposure, lung cancer is the outcome. So we start in cohort study with people who will be smokers. Retrospective cohort study is a different design. We will not discuss this in details and it is not very commonly done. Case control study is very commonly done. What do we have here? Here we have the outcome of interest. That is, we start with patients who have lung cancer and we evaluate whether they were smokers. So this is the key distinction between cohort study and case control study. Now, as I was mentioning, there are two broad components that you need to understand. Exposure is the factor of interest which may influence the outcome, also known as risk factor in medical terminology, but can be results of tests or treatment also. Outcome is typically the result of interest, which is usually the occurrence of disease or death. Sometimes we may use surrogate measures instead of true outcomes. Now, what are surrogate measures? Surrogate measures may be things like elevation of PSA, may be an example of a surrogate measure when it looks like the disease outcome is prostate cancer. Now, whenever you are dealing with surrogate measures, you have to remember that surrogate measures may not always be directly correlated with the disease or the outcome of interest. Let's start with case control studies. Now, case control studies, how do they work? They work by identifying the patients or subjects, usually who have the outcome at the outset. As I mentioned, outcome would be, example would be things like lung cancer. So once the outcome status has been identified, the subjects will be categorized into cases or controls based upon the subjects who do not have the outcome but come from the same population. What does that mean? It means suppose you have a group of patients who have lung cancer in your hospital and you want to run a case control study on them. You will say that the cases are the lung cancer who present to you in the outpatient department, while controls will be people who do not have lung cancer and would probably be matched to these cases in some way. Now, please remember, whenever you are doing matching, you should not match based upon the exposure of interest. What does that mean? You should not take people who are smokers and who do not have lung cancer as your control. This is very important. Now, why do we want to do case control studies? We want to do case control studies to determine if there is an association between a disease and a risk factor. Now, where it is particularly useful? When the disease or outcome of interest is uncommon. And common examples of this is cancer. Cancer is an uncommon disease in the population. So, case control studies are particularly useful when you are trying to define association with a particular risk factor. Now, let's take an example of a hypothesis to understand how this case control study can be designed. So this is an example of a hypothesis for a germ cell tumor. So we know that because germ cell tumors are rare cancers, we know very little about their etiology. In order to explore the risk factor for these malignancies and generate etiological hypothesis, please remember this word, etiological hypothesis. We are not going to define the etiology. We are going to define the hypothesis for the etiology. A population-based case control study of 105 children with malignant germ cell tumors and 639 controls was conducted. Now, what is bias? Bias is something that happens when we get a wrong association. So, what was our purpose? To determine association, right? But suppose we used a flawed methodology or a flawed design, we may get an estimate of association which is higher than what it would be or lower than what it should be. These are all examples of bias. There are two broad types of bias that can happen in case control studies. One is information bias. Now, information bias is what bias? Basically, it happens because of incomplete information related to the exposure. A very good example is recall bias. For example, people who have the disease may recall a bad event happening to them much more frequently than people who do not have the disease. Correct? For example, people may remember that they had taken oral contraceptive pills for 6 months as compared to women who do not have breast cancer who may not remember the same duration of oral contraceptive pill use. Interview bias is also very important, and actually it is a very, very important source of bias, not only in terms of the fact that interviewers may ascribe exposures based upon the way they conduct the interview. There is a possibility of intervention bias, that a certain group of people, by virtue of being more rich, by virtue of being more affluent, have greater access to a particular health intervention, which modifies the outcome. Selection bias can be introduced in case control studies, and this is the second most common type of bias. If the probability of including case or controls is associated with exposure. I would like to emphasize this once more. What does this mean? This means that suppose you are doing a study of case control study of lung cancer, where you want to see the association with a thing like smoking. Now, what you do is that you go and find out cases from the ward, in the chest ward, right? You go and find out. What do you see? You find out that patients who have lung cancer, and you have this group of people whom you will be finding out whether they have a history of smoking. The control, you decide to go to the community and select people who do not have exposure to smoking. For example, you may decide to go and select out people who belong to the same age group but who are not known to be smokers. Now, what will happen as a result of this? As a result of this, you will increase the magnitude of association which smoking has with the cancers, because you're in your control group, smoking patients or smoking people will be underrepresented, and in your case group, there will be more number of people who are smokers. So for case control study, you will have 4 broad steps, and these steps will be useful for you when you are designing the concept notes today. You start with identifying the population in which you want to determine the association. You define the cases and the control, and you measure the exposure of interest. So mind you, you start with the outcome, you measure the exposure. Now, what are the cases? Cases are people who should have the condition. So you need to have a good definition of the word case. So if you say lung cancer, then all forms of lung cancer can come into your case definition, and you may have to then decide whether EGFR mutated lung cancer should be your case or not. Now, this has practical implications, right? If you have EGFR non-mutated population, you would find that the etiological link to the risk factor like smoking will be different as compared to those who have a EGFR non-mutated lung cancer. The important thing is that you should not forget the temporal part of time-dependent endpoints. What does that mean? It means that suppose you are defining the case in such a manner that it will evolve over a period of time. In that scenario, you will have to take that time into consideration. For example, you are designing a trial or a study where you are looking at radiation proctitis. Now, radiation proctitis is typically a late toxicity, right? And if you design a case control study where your cases are any patient of cervical cancer who has received chemoradiation, you will have a serious problem. The serious problem being that people who are, say, within first year of chemoradiation have a lower probability of developing radiation-induced proctitis. So you must wait for a sufficient period of time. The cases should be representative of the population. It makes no sense to conduct a case control study in people who are extremely privileged or people who are extremely underprivileged. It should remember cases will recall a greater amount of information as they have the condition, and this is an example of a recall bias. In the choice of case definition is generally based on validity. What does the word validity mean here? The validity means that you should be able to confirm or validate that case is present by an independent methodology. So for example, if you chose lung cancer as your case definition, then how would you ensure validity? You would ensure validity by specifying that all my patients of lung cancer should have a biopsy proven lung cancer. Now, whenever you use the word biopsy proven, what does that exclude? It excludes people who have a radiological diagnosis of lung cancer or who have a clinically suspected diagnosis of lung cancer and so on. You can decide to make this even more narrower. You would say that I would want to have patients who have a tissue diagnosis rather than, say, evaluation of circulating tumor DNA. In this way, your case definition has to be made very stringent. You have to decide whether you want to take incident cases, these are newly diagnosed cases, or prevalent cases, that is cases which were already existing. Now, it is important to understand that incident cases are better. Why? Because in prevalent cases, you tend to get people who survive longer. It makes sense, right? Suppose you are taking a cohort of lung cancer who comes to your follow-up OPD. You will have people who tend to have a better biology disease, lower stage disease in your cases. Now, if the exposure of your interest is associated with the aggressiveness of the disease, taking a prevalent cohort will result in an underrepresentation of that association. Incident cases are also useful because they recall the disease associations or the exposures with much greater precision. Now, where should you do the selection of the cases? Should you select it in the hospital or should you select it in the population? And this is a very commonly given example, but it is a very good example, which is why I will repeat this. Is that suppose you are doing a study on association of smoking with lung cancer. And what happens if you select the cases from the hospital, or even better, you select it from the OPD? What will happen is your controls will typically be people who have things like COPD, emphysema, asthma, interstitial lung disease, etc. Now, all of these have certain association with smoking. Now, whenever you select controls from this group, it will drive down the association between smoking and the cancer of interest. To mitigate this, if you are doing hospital-based, the next question is, should you do a single case, single hospital, or multiple hospital? Now, I think it is very easily understandable why multiple hospitals will be better, right? Because access to a hospital is determined by factors like your socioeconomic status and your geographical area of residence. So multiple hospitals would be definitely a better way to mitigate these biases. Population-based case selection is of course better. The problem is of course finding the cases, because diagnosing the cases in the population is different from diagnosing the case in the community, in the hospital. For example, if we take that example of lung cancer, where we were looking for a tissue biopsy. If I say that now I will go and do biopsy in the population to evaluate whether they have lung cancer or not, you can imagine how my study will go. In population-based cases, it will also be difficult to ascertain the date of onset. Now, typically, why that is the case? Because you may often go to the population and ask for them whether they have a history of lung cancer or not. Now, they may be able to tell you when they had the lung cancer, may not be able to tell you when they did not have lung cancer. The more difficult task actually is to choose the controls. Why? Because control should be chosen from the same population, and we basically want to get an estimate of the population prevalence. Now, proper identification is of course essential, because as I mentioned, if you do not identify your controls in a proper manner, you run a serious risk of getting a selection bias. A nested case control study often done is a case control study which is nested inside a cohort study. Now, what happens here is that you essentially have a small proportion of controls which are compared to incident cases, and it relies on the use of something called as matching. Now, what is matching? I introduce this word now. Matching is basically a technique by which we try to reduce variability arising out of other factors between cases and controls. Now, please remember, whenever you are matching, you are not matching by the exposure of interest. So, once more, what is the exposure of interest? Say if it is lung cancer, you would not match by things like whether the patient is a smoker or not, whether the patient had exposure to oral tobacco or not, how many pack years of smoking the patient had. You will not match by that. You will match by other variables like age, gender, and so on. Controls can be from a nested case control study. You can have population-based studies where controls can be selected from, say, things like clusters of villages or schools and so on. And hospital-based controls, these are usually the easiest to obtain because you have a captive population. But as I mentioned, they may not represent the population of interest because of referral and case selection paths. Now, matching of case controls is important in certain scenarios. As I was mentioning, when you are using nested case control studies, you would often match for variables. However, matching is not so easy. Why? Because matching should not be done on the exposure being investigated. And good example is this. Suppose you are interested in finding out the association between ovarian cancer and exposure to oral contraceptive pills. What you are looking for is this association. But what happens if you match people on age? What happens is that age is a confounding factor because people who are at a certain age group have a higher tendency of getting oral contraceptive pills as compared to those. And what happens is if you do match on this, you end up in understanding or getting a lower estimate of the effect of oral contraceptive pill use on ovarian cancer. So that is why matching needs to be done very carefully. What are the types of matching? You can use individual case matching or a frequency matching. Individual case matching is basically what? You have, say, a gender male, you match it with a gender male. Frequency based matching is what? Basically, in your control cohort and your case cohort, you essentially try to keep the frequency of that match variable to be the same. So, suppose you have 50% females in this cohort, you will give 50% females in the other. How do you measure the exposure? In a case control study, remember what you are measuring, what you are trying to get in the study is the exposure of interest. So, it is important that you have a standardized data collection. This is extremely important because if you do not have a standardized data collection form, you end up having a scenario where your data is mixed. In fact, whenever you are doing a case control study, it is a good idea to design forms that actually give an interview so that people who are interviewing for determining the association can interview in the same manner. That reduces the observer bias. Now, this is a bit of mathematics, but it is important to understand what is the difference between odds and risk. And we come to this because odds and risks are odds ratio and risk ratio will be the thing that you will be reporting when you are going to report these kind of studies. So in a case control study, you will typically report the odds ratio. In a cohort study, you would be reporting the risk ratio. Now, odds is the ratio of the probability of the event occurring to that of not occurring. So, for example, if you take this example, let's say you have done a study where you had people who received radiotherapy for some indication, say brain metastasis, and patients who did not receive radiotherapy, say for brain metastasis. And you found out how many are dead or alive at the end of, say, 6 months. You saw that in 110 patients who received radiotherapy, 10 people died. And in 15 patients who did not receive radiotherapy, 5 people died. So what is the probability of dying in the radiotherapy group? It is 10 divided by 110. What is the odd? The odd is the probability of death, 10 divided by 110, divided by the probability of not dying. So this is 1 minus 10 divided by 110. Why? 1 minus this probability gives the probability of not dying. Now risk is the probability of the event occurring, as I mentioned. So risk of death is 10 by 100. So you see, odds and risk are two different concepts. Now, why do we use odds ratio? Because odds ratio have a very useful phenomena that you can essentially use them in case control studies. To use risk ratios is a problem in case control studies because you do not have a good idea about the incidence, and we will come to this when we come to the case cohort designs. It reduces the effect size in large studies as compared to risk ratios, and it is also more conservative, which means suppose you use a risk ratio in larger studies, risk ratio will be higher than the odds ratio. And confidence intervals of odds ratio can be calculated. Most of the regression models that will be used for the analysis will be reporting the odds ratio. What are the limitations? You have selection bias, information bias. As I mentioned, temporal relationships between exposure and event can be often difficult to establish, and this is very important. Suppose you need to do a study of a case control study, you have to establish that the exposure happened before the outcome of interest. If it happened after the outcome of interest, it is of no consequence for you. Estimate for incidence of the disease cannot be obtained, and conditions where the exposure is rare are difficult to study. What are cohort studies? Cohort studies basically are different. Here we are starting with people who have a defined characteristics, and from them we decide how much is the incidence of the disease occurring. The word cohort is derived from this Latin word called cohorts. Now you know these people, Roman legions. Now Roman legions had 10 cohorts, and these cohorts had a specific number and a specific banner. So during the battle, the military commanders would be knowing where each person was. In other words, the commanders would be knowing where each cohort was fighting, and they would be able to pass orders to them in a direct fashion. Now for cohort study, what is very important is what is the population of interest when you are designing cohort study. You can do population-based cohort studies on a general population. Very good example is the Framingham heart study. You would have all read about this in your community medicine textbooks. And this is a very, very important study. Why? Because it took people who were located in this city. That's why it is called like the Framingham heart study, right? As you can understand, this is an expensive and a large scale study. So you are starting with the population of an entire city and you are trying to determine what happened to them. And because of this, you can evaluate several outcomes at once. Now please remember, this is a very important point. Cohort studies allow you to find out outcomes. Therefore, a cohort study can be designed to find out multiple outcomes. Case control studies allow you to find out exposures. So in a case control study, you can find out multiple exposures. You can conduct cohort study in a socio-economic group, like the DAWS study of registered medical practitioners from UK, where they showed that medical practitioners tended to have very high rates of substance abuse, suicides, cardiac deaths, and so on. You can do it in high-risk groups. For example, in studies related to occupational safety or studies where there has been an exposure to an intoxicating agent. For example, like our union carbide accident. In Bhopal, there is a cohort study which is running where they are evaluating these findings. In cohort study, you can have two types of comparators. You can have the internal comparator, where the comparison group is obtained from the cohort itself and classified based on the degree of exposure. This is usually quite good. So, for example, if you are doing a study in the general population, what you can do is that you can have the entire population in front of you, and you can ask them, like, okay, are you a smoker? Are you a, how many cigarettes do you smoke? You can understand that people who are current smokers will be able to report it with much greater accuracy now than 20 years down the line. So you will have much better ways to find out. Now, external controls will be useful when there is exposure is uniform. So, for example, let's take that example of the Bhopal gas tragedy. Now, if you take the cohort of people who were residing in that area where pesticide exposure was there, all the people would have had exposure to the pesticides, right? So, finding out a control group which did not have exposure to pesticide would be difficult. So, you would have a cohort of people who had exposure to pesticides, but you will have an external control or an external comparator group who did not have the exposure of interest. So, for example, you may find out another area in near Bhopal city which does not have the exposure to the pesticides. Now, selection bias can occur in the choice of the comparison group if exposure risk in the control group is not well defined. What does that mean? Suppose you have no idea of how much exposure has happened in the control group, you will not be able to find out. So, if you are using a poor quality questionnaire, for example, you will not be able to find out how much smoking the person has done. Outcome data for the control group is missing. Now, please remember, cohort studies are what? They are studies which follow up people over a long period of time. And as a result, suppose your control group is not being followed up in the same intensive manner as the cases, you will have a problem. Now, this will happen if you are doing studies which are cohort studies which are doing things on occupational safety, which are doing studies, in terms of toxicology and so on. You may be following up people who have exposure to the toxin of interest or the occupational hazard of interest in a much more closer fashion as compared to general cases. A very good example is, lung cancer and exposure to asbestos. So, if you are doing a cohort study in asbestos minors and you take a normal control group and you try to find out how many of these have developed mesothelioma later on. Now, for the patients or the people who are in the asbestos workers group, an occupational chest X-ray may be mandated by occupational safety for them. But the same may not be the case for the control group, and therefore you will end up with different outcome data. Cohort study is defined. So you start with the Framingham study. You say all people in the city of Framingham will be exposure data is collected in the present time. So you start collecting out things like their blood pressure, their sugar, their cholesterol level, their smoking history, and everything else in the present time. And you follow them up with outcomes in the future. A retrospective cohort is where the exposure measurement is done using reliable records. For example, you may be doing something like a baby's birth weight as the exposure of interest. You can do a cohort study because the baby's birth weight would be recorded reasonably well, and it would be recorded in the data sheets very well and robustly. You may be able to do a retrospective cohort study in low birth weight infants, for example. Now, very important to understand that because this is a prospective design, you can eliminate biases like selection bias, recall bias in much better manner, and therefore confounders can be measured reliably. This is usually the design of a cohort study. What you have is from the population, Now this is where the incidence part comes in. Please pay attention. You have an entire population where some people have the disease and some people are disease free. You pick up a group who is disease free. So you have to define this cohort that these people, for example, should not have lung cancer. If you want to design a cohort, once you design this disease free cohort from a sample from this population, you follow all of them up, find out the exposure to the factor. This you can find out whether they are smoking or not, and then find out how many have the disease. Now, because this group came from this group, whatever is the incidence of disease in this sample can be extrapolated to the incidence of the disease in the population. That is why cohort studies can give you incidence, can give you things like relative risk, by case control studies cannot. How do you interpret relative risk? It is quite simple. It is more than one, it means there is a greater risk of disease. It is less than one, it means there is a lesser risk of disease. What are the limitations of these? Expensive and time consuming, and as you can imagine, if you are doing something like a priming study, this has to be done with a huge amount of infrastructure and resources. You probably need to have a proper healthcare system which can deliver care for these people. Now, please remember, whenever people are going to participate in a cohort study, they are not going to do that study for you to fill up questionnaires. They come for you for proper care. So the care has to be provided and the arrangements for the care provision has to be made before the cohort study started. Information on exposure can influence the assessment of ICU, as I mentioned. Suppose you know that the person is having smoking. Would you want to do more frequent screening for these people for lung cancer? Maybe with a, say, low dose CT scan every 5 or 10 years. And finally, loss to follow-up. And loss to follow-up can result in selection bias. Why? Because suppose you have a cohort study where people who are doing well or doing poorly are lost to follow-up. A very good example can be an occupational cohort study where people who become too sick to work leave the work. Say, for example, you are looking at asbestos workers and you want to determine the association with mesothelioma. But workers who develop COPD before they develop mesothelioma may not end up working, may lose their benefits because they have retired or they have lost their jobs and therefore get out of the cohort. So that's why this form of bias can be very insidious but can happen in cohort study. The next thing that I want you to pay attention to is a retrospective chart review. Many of you will be doing this. And why you will be doing this? Because you are dealing with a rare disease or a rare outcome. You simply do not have the funds, or you need to design a hypothesis. You need to say calculate a sample size. Most commonly, you probably need a quick paper. The key aspects whenever you are designing a retrospective cross-sectional audit case study is that the protocol has to be defined a priori. I hope that you are getting a strong amount of in this course on this aspect. If you do not have a priori protocol written up and you start to collect data, you will invariably end up with false associations. So that's why do not start data collection before deciding what you are planning to write. And my recommendation always is to come out with a full protocol. You can look at things like the stroke guidelines to help you write up these protocols in hand. You have things like comparative effectiveness studies. What are these studies? These are observational studies which aim to utilize health data. Now, please remember, health data is obtained from your electronic registries and so on. It is not something that you figure out for a small group of people. Health data should be captured systematically. And what you are trying to do is compare the effect of different interventions. Please remember, these form of studies are not supposed to be done at hospital level. They are supposed to be done at regional, state, or national levels. And a good example of these are studies which are done from Netherlands, where outcome data for all patients treated in the country is included. That is a good example of this. Now, Archie Cochrane, who was a very famous clinical epidemiologist, you may have heard of his name, defined two concepts related to assessing healthcare intervention. Now, efficacy is the extent to which an intervention does more good than harm under ideal circumstances. This is what you determine from a trial. Effectiveness assesses whether an intervention does more good than harm when provided under usual circumstances of healthcare practice. And this is what you will be able to find out from such studies. Comparative effectiveness studies will generate evidence regarding the effectiveness, once more, effectiveness, not efficacy, in the general population. A word about restriction and matching. You have heard about matching from me already. Now, what is restriction? Restriction is the use of inclusion or exclusion criteria to study a similar set of individuals. What are you trying to do? You are trying to basically restrict the study to a certain group of people. That's why it is called as restriction. Now, what does restriction do? It reduces your selection bias. Known. Keep in mind, known, not unknown. You cannot restrict for unknown confounders. The problem with restriction is you land up with a smaller group of people to study, and therefore the power of the study to find out an association reduces. Why? Power side is dependent upon sample size. Matching means what? You essentially link individuals with similar characteristics in the group. So what you are trying to do, you are again trying to reduce selection bias, but this time instead of having a very strict inclusion-exclusion criteria, you are trying to make sure that the distribution of these factors is same. There is something called propensity score matching, and some of you may have already used it or you are going to use it in your studies. This is basically a regression-based technique, typically a logistic regression-based technique, which generates a single score based on the levels of the different variables which you are trying to match to. Now, mind it, propensity score-based matching has several problems, and I don't have time to go into that, although it is commonly used as to say that the study is a quasi-randomized controlled trial. That's not correct. So to conclude, observational studies are crucial components of the effectiveness chain. They have importance. Why? Because they allow you to determine the effectiveness of an intervention. They allow you to generate hypotheses, and they allow you to estimate causality. Therapy efficacy. This is very important. Therapy efficacy, however, needs randomized controlled trial, and many of you would have come with designs of randomized controlled trial, which is very good because those are the only designs which will allow you to judge the efficacy, nothing else. It is important to remember quality observational studies are vastly more complicated to design as compared to randomized controlled trial because you have to take into account several biases and sources of confounding, which requires significant amount of thought and pre-planning. And with that, I would like to invite you all to join us for the second Recode with R course, which will be organized online. This is the website. You can find out. This time, we will be focusing on data management. This is a 3-day online course with an intensive hands-on experience. And thank you. I would like to thank my team, which enables me to go out and participate in workshops and conferences like this.
Thank you. Hello. Thank you very much, Sandam, for a very comprehensive take on the topic of observational studies. And I really like the fact that you emphasize so much on the bias associated with observational studies because, while we are developing a lot of protocols here, bias keeps coming up quite often, in the way we look at study designs and methodologies. So I think it was an excellent talk, in my opinion. And the floor is now open for questions from the audience. Any questions? Do we have any questions from the online audience? Any question? Dr. Dennis, you have something to ask? So, Sam, just one question for you from me. So, people always, often get confused between relative risk and odds ratio. When should, each of these parameters be used, and what is the meaning of, because sometimes they tend to use it interchangeably. So, can you throw some light on what is the meaning of odds ratio and what is the meaning of relative risk and how distinct they are?
As I mentioned, odds ratio is the ratio of two odds. So what is odd? First you have to understand odds is something very different from risk. What is risk? Risk is the program. Am I audible?
Yeah, yeah, you are.
Okay. So there was some back. That's why I was asking. Anyway, so odds is basically a ratio of two risks. What is relative risk? It's a ratio of the risks between the two groups, while odds ratio basically ratio of odds of two groups. So it's a ratio of the ratio is odds, and relative risk is basically a ratio of two risks basically. So when do you use odds ratio? You use odds ratio in control designs where you do not have a population where you can define incidence. That's when you use odds ratio. In case of cohort studies, where you have incident population, that is what I saw the incident population, you can use the relative. First, if I go back, let me share the screen. So if I go back, so what does this allow you to do? Study, what is this contingency table you are getting? You are getting in this sample, which were initial mind you and derived from the population, how many develop is when they get exposure to factor, right? So you can directly estimate the risk of disease in the exposed group. That is very easy. So what is that? It is the number who developed the disease divided by the total number who were exposed. But you can also estimate the risk of disease in the unexposed group. This is the key. So what you are able to do, define B who had the disease in the unexposed group divided by the total number of people who did not have the. This is something that you can get from case control studies. Why? Because you do not have this incident population, right? You only will be able to find out, you will be able to determine their exposure peak, but you will not be able to find out how many truly who were did not have lung cancer did not have exposure. This is the difference, and that is why in a cohort study you can define the relative risk, because these are the two factors that you can simply divide and get a relative risk. On the other hand, in the case control study, you can only get the odds ratio. Am I making myself clear?
Absolutely, absolutely. I hope it is clear to everyone because this is a very important distinction between the two ratios. Okay, it is very clear, Sandam. Thank you very much. Any more questions? Okay, so if there are no more questions, we come to the end of this talk. Thank you very much, Sandam, for joining us, and we would love to have you here in person. But yeah, I got to know that some of your other commitments kept you from traveling. But
thank you very much for accommodating my request, Vikram.
But yeah, next time definitely we would want to have you here, Sandam.
Yes, I will try my best.
Okay, all right. Bye. Thank you.
Bye.
So the next lecture is from Professor Dennis Xavier, who is Professor and Head of Department of Pharmacology and ex-Vice Dean, Head and Division of Clinical Research and Training at St. John's Medical College and Research Institute, Bangalore. He's a good friend of mine, and it gives me great pleasure to invite him to deliver this talk on phase 2 clinical trials. And Dr. Dennis has considerable experience in cardiovascular clinical trials. And then, if you go back and search his profile, he has published in, he's a very prolific publisher, and then he has got publications in some really top-notch journals, and it will be an absolute pleasure to listen to him. So talk on phase 2 clinical trials.
All right. All right, systems are working, but you have been sitting down since what time? 8:30 probably. Why don't you stand up for 30 seconds? Stand up, everybody. Stand up, stretch a bit, however you want, except punching your neighbor. Stretch a bit, take a few deep breaths. Okay, breathe in, everybody. Breathe in. I didn't tell you to breathe out. Do that again. Hold your breath for some time. Breathe in, everybody. Breathe in. Now breathe out. Once more. Third time. Breathe in and breathe out. Stretch a little bit, shake a little bit, smile, sit down. Okay, it took us less than 30 seconds to get a little more energy, and we need that energy to continue listening. So I was given 35 minutes. So it's quite a challenge to be a third speaker after such wonderful talks and to be in the way of your cup of tea. But I will do my best. Can we have a little more lights here, actually, if that's possible? Uh, because I have a dark background, so the slides can be seen. Okay, so how many of you, I'm going to do some, we're going to discuss clinical trials. So how many of you have designed a trial and conducted it? Other than you, Vikram, I mean, not the faculty. Yeah, that's great. Yeah, I'll leave it at that. Perfect. Okay, now you can see me when I'm sleeping, right? Okay, so how many of you have designed and conducted a trial? No. Okay, one of you. How many have been a part of a trial with somebody else? Did you either to consent, you collected some data, you did something, etc., etc.? Okay, okay. Oh, fantastic. That's 3/4 of you. Okay, good. So what we're going to do is I'll give you, so this although the title says phase 2 trials, I'm going to do it in 2 parts, and I'm going to do it really quick because my life has been made easy after Shankar's talk in the morning. So a lot of what I wanted to cover and explain, he has covered it, so I can mention it once more and go ahead, right? And I hope at the end of this, what you would get is insights on designing and conducting by yourself an academic clinical trial, right? Unless you're planning to shift to industry, hopefully not very soon. Okay, right? But anyway, there are some wonderful people in industry as well, and I have lots of friends there that way. Okay, uh, I want you to think about something. You have a paper and pen? Quick, quick. We need to do it very fast because we have very little time. Okay, so I'm going to ask you a few questions. You need to write a few words only. Okay, don't answer the full question. Okay, very quick. We'll do it because we don't have time. Okay, and you know what's a perfectly valid answer? IDK. What's IDK? But write IDK. Okay, you can write IDK in 1.5 seconds. Okay, first one, what is clinical equipoise? Just put question number 1 and say clinical equipoise. Okay, what is clinical equipoise? Just write, no need to write the question, just write a few things. What is the meaning of clinical equipoise? Okay, second question. We all hear about randomization, right? We divide into 2 or more groups, whatever. What is the purpose of randomization? Why do we randomize? Question number 2, why do we randomize? Third question, benefits of blind. What are the benefits we get? So write some abbreviated answer. That's enough. Fourth question, you know the answer very well to this, which is what are the challenges with oncology trials, with newer oncology products? So what are the challenges that we have in conducting new oncology studies? let's go to the fifth question. We all heard about adaptive trials. We've heard about that. Okay, my question is, are adaptive trials more ethical? So yes or no answer. So question 5, you write Y or N. Okay. And for each of the response, just write 1 or 2 words on why. If you say yes, it is ethical, why? No, it is not more ethical, more and less ethical. Why? And I have a last question for you. Right? And this is from where the previous speaker left off. Right? He said, for evaluating efficacy of any product, you only need to do trials, isn't it? You can't do it with observational studies. So in other words, why? In other words, why is RCT the only method or the gold standard? There's nothing else you can do for evaluating any product, drug, device, therapy, radiation, whatever. Okay. Okay. Anybody wrote IDKs for anything? No, right? So you wrote something. Oh, many IDKs. Wonderful. Writing IDKs is great. It's my favorite thing to say. So previously, my students would, oh, I don't know about that. Can you explain that? They'll wonder, how can a professor not know things? Actually, professors know very little. That's the truth. Okay, let's move on. What are we going to do today? First, we'll get an overview of a few key concepts in randomized trials, and then we'll look at some methods of phase 2 trials. We can take one method and discuss it the whole day. Okay, but we'll just get a quick overview. What contents we'll speak about quickly, we'll recap. Although I was not there yesterday, you did the components of a research question, right? But we'll quickly recap this for an RCT. I'll give you a template as well. And those of you doing RCTs for your project, keep this template in mind. I'm going to show that to you shortly. And then we look at very quickly randomization, allocation, concealment, blinding. When I was doing my master's course in Canada at McMaster University, it took me a little while to understand these things: randomization, allocation, concealment, and blinding. And for my thesis defense, I was asked this question actually by a diabetologist, not even a statistician. He asked me this, and I don't think I gave a very good answer, right? But anyway, that time we were still learning. This is 2005, long back. Okay. Then we look at designs in traditional RCTs, and we look at some challenges in cancer trials, and finally some novel approaches. Unlike Dr. Shankar in the morning, who is a statistician, and you saw lots of algorithms and statistical notations. I couldn't see it from the back even, right? But I'm not going to be touching on all that. Let's get some broad concepts. And for me, getting clarity on a concept will help you go and learn more about it. Okay, so that's what we'll do. Okay, so or in other words, how do we write a research question for an RCT? So we need to define the patient or the population, the intervention, the comparison, and the outcome that is being measured. So in a trial, we can go a little further, and you must write over what time period. What is the effect of this drug over 1 week versus 1 month, over 1 year, over 5 years? It makes a difference, right? And then you can also mention the study design or hypothesis. Is it a non-inferiority or a superiority, or whatever design? Okay, so with that, let me give you a template for a question. Okay, so among patients with a particular disease, so that is our P, patients, does intervention A, that is our I, okay, compared to standard therapy or intervention B or placebo, whatever it is, that's our comparator, modify or reduce complications or death, or modify biomarkers, whatever, at this particular time period. Okay, friends, so this is how we write a research question for a trial as such. With that, let's move on to understanding who are the people we take in a trial. The population must have clinical equipoise for that particular treatment, whether it's even radiation. Clinical equipoise simply means what? It looks like a very complex question. No, there is no clear indication or contraindication for that therapy or intervention. If there is an indication, everybody should get it. You can't have a control group, no placebo group. If there is a contraindication, nobody should get it. So we are in that stage where there is sufficient evidence for us to say, I need to try it and get clearer evidence. Okay, of course, safety goes without saying. Next, our population must have a high chance. See, when we use the word risk, we think it's something bad. Okay, it need not necessarily be. Okay, in epidemiology, risk is a chance of something happening. Must have a high risk or a chance of either study response or outcome. So this is highly desirable. We cannot wait for something for 7 years to occur, right? We need it to occur in the time that's available for us. Next, our eligibility criteria must have good external validity. What does this mean? When I get the results, this must be used for the patients or the population who have not been part of the study. All right, so that's what we need to do. And of course, you know, when you see early phase studies, you'll have eligibility criteria on half a page, and you'll have exclusion or inclusion criteria on half a page. Exclusion will go to 2 pages. Know this. If somebody has gray hair on the right side, don't exclude them. Okay, I'm joking a bit, but try to keep exclusion criteria. Take it as a challenge. In your studies, keep exclusion criteria as small as possible so that more and more people can benefit from it. Early phase studies is a bit challenging, but keep that in mind. Okay, what are the different types of interventions? All the examples are in cardiology. All my work has been in cardiology, so you know, adapted to oncology. Okay, drug therapy. We can have medical procedures. We can have surgical versus medical procedures. You can have surgical versus medical versus radiation, right? And you can have health systems intervention. And I would like you people to start thinking about this as well, because massive changes to large populations can be made with health systems intervention. Yes, drug, all this is important. And finally, something called complex interventions. And I'll tell you about it. You can take a picture a little later. Hold on. So drug therapy, any drug, you know that, okay? Medical procedures, radial versus femoral artery access for angioplasty. So we actually did this trial and we found that it was similar. So radial is actually easier to access and outcomes were similar. Surgical versus medical procedures, medical procedures, ECT versus medical therapy in refractory depression, let us say. Lifestyle versus medical therapy in pre-diabetes, not diabetes, it should be pre-diabetes, right? Surgery versus other procedures. Health systems interventions. Can we use non-physician health workers to improve outcomes after a cancer diagnosis, after a myocardial infarction? So we've done studies like this. In fact, this was a study that was funded by the NIH. I got a grant about 10 years ago, and we published this in the Lancet. We found good outcomes, so we can do that. Complex intervention means many different types of interventions done as an interventional package. It's called an IP or an interventional package. So we have behavioral therapy, mobile reminders, and home visits for somebody who's going back home after after treatment for cancer or after an MI. So different types of interventions. Why is the control important? The C in RCT, why is it important? It improves internal validity. It gives us good results for the population on which we are trying them out. And then we can have meaningful comparisons with a new intervention. Now, what should be a control? It depends on the standard of care at that time. And in other words, it must be the best available treatment. Best available treatment at that time. Cost or inconvenience, whatever, doesn't matter. That's the drug we need to choose. Right. If there is no effective treatment for that condition, we do a placebo-controlled trial. These days it's becoming more and more difficult to do placebo-controlled trials because we pretty much have treatments for all conditions. So we do active control trials, and this is a drug that's recommended by guidelines. Let's move on to objectives in our trial. The primary objective must be absolutely clear. Yesterday in our group, I was recommending to our people, just have one good, clear primary objective, right? Let's not have 2 or 3. Actually, statistically, it's a painful thing to have more than one primary objective. It's called co-primary objective. Then statistician will tell alpha spending. What alpha spending? I don't have much money to spend. No, not money spending. This is alpha spending. So you have a long discussion. Oh, not 0.05, 0.0025. Why all that? Okay, so keep one. So for studies at your level, please have one clear primary objective that must be statistically powered, and it determines the sample size. Secondary objectives, you must define it a priori. That's important. You can't, while the trial is going on, you can't add on objectives, right? And no post hoc fishing expedition. Based on the results, I'll write some objectives. So people have done it. Now these days you can't do it because you've registered your protocol. That's it, right? And any changes is a formal protocol amendment. Okay, right. Let's move on to outcomes. So again, primary outcome. This confirms whether this treatment works or not. Right? It measures the outcome of the primary objective. It drives the analysis, right? And it measures the efficacy of your intervention. Secondary is a little more exploratory, and it generates and supports some hypothesis. Okay, let's move on to randomization. That is one of the questions I asked you. It's a process of assigning patients by a random process. If I ask you what is a random process or what is randomness, and if you're able to explain it, it is not random. Okay, you always wonder. So we humans cannot be random. Nature is random, right? So we cannot try and figure out what random is. Okay, so we have at least one control and one test treatment, and treatments are given based on this random process. What is the purpose? Why do we take all this trouble? And this is why an RCT is a gold standard for evaluating treatments, because we produce comparable groups that eliminates treatment selection bias. Number one, very, very important. This was another question for me because my thesis was an RCT, and that paper got published about 3 years later in the Lancet. But this is another question I was asked in 2006. So randomization protects against both known and unknown confounders. Propensity score matched analysis. I've seen a paper which had 150 propensity scores that were matched. Still not good enough. Still not good enough. We don't know. So those 150 were the known confounders. What about a few more unknown confounders? Okay? So randomization is the only. How it does it? If you explain it, then it's not really random. So don't worry about that. Okay, it happens really nicely. So finally, we achieve a balance of prognosis between treatment arms. So what's the only thing that is different between the treatment arms? Absolutely. The treatment that you're giving. The treatment that you're giving is the only one that is different. Okay, so let's move on. Methods of randomization. Fixed methods, we will talk about fixed randomization, which is constant throughout the trial, and adaptive, which changes during the trial. The fixed allocation randomization, you're familiar with this, simple, blocked, and stratified, and adaptive changes during the trial, and I'll tell you a little bit about it towards the end of this discussion. Trial designs depends on the research question and what is known at that time. So the commonest is the parallel group design, then we have the crossover design, we have the cluster randomized trial, then we have the factorial design, then we have the pragmatic trial. I was recommending this to one of our colleagues in our group to try out the probe design. Probe stands for prospective, randomized, open label, but with blinded evaluation. Okay, so it's open label, but the evaluator is blinded, does not know where the treatment or what treatment this participant is allocated to. Then we have other superiority, equivalence, non-inferiority, and some adaptive study designs, which I will tell you briefly about just now. People confuse between blinding, randomization, and allocation concealment. Allocation concealment, when you conduct a trial, this is important and you need to take some care in doing it. What does allocation concealment mean? It means protecting the sanctity of randomization until the participant is randomized, until the participant is given that particular treatment. Till then, you will not know. Till then, nobody should know, particularly the investigator or the patient should not know. Okay. So, in other words, not revealing the treatment allocation till the patient gives you consent and the process of randomization is done. Now, how do we do this? The simple process is called the sealed envelopes. All of us have heard about it. It's also called sequentially numbered opaque seal envelope. Sequentially numbered opaque sealed envelope. All of that is important. It must be sequential, it must be numbered, it must be opaque, right? And it must be sealed. You cannot have it in a list, open and keep ticking off. Why? You will know what the next one is. You will know what the next one is. And why is that important? Many students do this and then say, no, it's okay. It's only a student thesis. It's okay. No, certain things, okay, you need not do exotic, expensive things, but certain critical things you must do well. Okay, so snooze is a reasonable option, but we are all honest and well-meaning people, researchers, and I mean it in a nice way. You'll open the envelope, you will see it. This is not good for this patient. Why? Because I'm a good person. Put it back, okay, and then you take another one. Who will know? Nobody will know. You believe nobody will know, but the statistician who made the randomization sequence, when he is analyzing it later, 3 months, 6 months, but sir, but madam, this number is all out. No, no, that patient, this happened, that happened, gone. Your randomization is messed up. So we did this for one of our trials, and I highly recommend not to use this, It looks convenient. So therefore, what's the other solution? There are other solutions, okay? So I would recommend prepare the sequence, keep it with an independent person, somebody who you don't like, and that person should not like you. You should not be good friends, okay? Right? And I'm serious about it because you can't, hey, next sequence, kya, thoda bata dena na? Before I take consent, just tell me. No. This is violating things. You are messing up the science. People do this all the time. So that's why I told Dr. Vikram, let me do a few basics, because this is the only session on RCT that was there, although I wasn't sure what Dr. Shankar was doing. But anyway, so these things are practically important for you, even before we dive deep into complex, phase 2 designs. Okay, let's move on. There are other sophisticated processes in multi-center studies. We use the interactive voice response system, but now it is all web-based. There are free softwares available now. You can do a few hundreds of patients, you can do it and maintain it. It's all available. So I would recommend either this or the IWRS for you to. Please don't use the sealed envelopes. Never have it in an open list, keeping it in your OPD drawer. Open and see next what is there. Based on that, you take consent. I don't mean this in a sarcastic way. We are well-minded people. So therefore, we should not give an option for that. That's what I'm trying to tell you. Create systems in such a way, there is no option for it. Okay. Oh, what happens? Oh, sorry. Just like when you dial a bank or any place, press 1 for this, press 1 for this. So first what IVRS or IWRS will do is it'll ask you for eligibility. Then it'll ask, are you ready to randomize? It'll check eligibility. You click on yes, on the web, if you click yes, I'm ready to randomize, it'll reveal to you. Suppose it's a medication box, okay? They'll tell, okay, the next number that you have to pick from there and give is 10731. You pick that up and you give. The next one is 10736. It won't be 72. So you have to pick it up. And that sequence is maintained. Got it? So this is possible now. Any statistician will help you with this. So please work with statisticians to get these simple things sorted out. Blinding, withholding the knowledge of treatment throughout the trial, okay, until the last patient is followed up. For the patient, there is some psychological benefit of getting some treatment. Okay, so they know that, right? In open trials, this is not there. So for the investigator, it reduces observer expectancy bias, what is coming next, and also ascertainment bias. Lots of studies, smaller studies in oncology, is got to do with quality of life, tumor size, and certain other soft or surrogate markers. All of that will get affected when ascertainment bias comes in. Okay, this is the classic parallel design. Sorry, I'm just going to grab a bottle of water. Yeah, thanks. Okay, so this is the parallel design. Your participants have fulfilled eligibility criteria and provide consent. Then you randomize. And this is called the allocation ratio. Thank you. I'll just leave it here. Yeah, thank you so much. This is called the allocation ratio. And in oncology, you will see allocation ratios varying. You will have more of treatment or less of treatment for different reasons. We'll not go into that. Cost and safety, or cost or potential adverse effects, is one of the reasons for varying the allocation ratio, right? So as you see, this continues in the same. That's why it's called parallel design. And when you cross over after a period of time, and if it is a drug, you need to ensure washout has taken place. And there are advantages of doing that. We'll not go into all of those details, but I wanted to emphasize the allocation ratio with this. Now, yesterday there was a session when I just came towards the end on how to write a protocol and quality of RCT. So it made my life easy. So the Spirit 2013 statement is there, and then This is what SPIRIT stands for, Standardized Protocol Items Recommendation for Interventional Studies. It has clear guidance, and there are 33 item checklist. And for different types of trials, there are different additions to this. And then consort is for reporting trial. This is for writing a protocol. This is for reporting the protocol. It's 2010 statement, consolidated standards of reporting trials. It's a 25 item checklist for reporting the trial. We have specific to designs, data, and intervention as well. Now, I would recommend you to go to equator.org. Please write that down. Okay, don't go now, just write it down. It has all of this. It has a list of all of this in real time. If yesterday there was an amendment, today it's there on the website. Okay, so you don't have to keep changing. What is this 2010? Where is the latest one? Is it the latest one? So 2010 is the original statement that was there. All the updates for different types of designs comes here. Okay, so equator.org. Okay, oh, by the way, any standard journal will ask you for the consort statement when you submit for publication. It will ask you these 25 items. You need to fill it up and give it to them. Okay, active control trial. We briefly spoke about placebo control trial. Active control trial is when a placebo control trial is either not feasible or not ethical. Then we do an active control trial. If you believe that the new treatment is better than the standard treatment, you design a superiority trial. If not, you design a trial to prove that the new treatment is not inferior or not worse off than the standard treatment, not worse off by a particular margin, which is called the non-inferiority margin. It's a big deal on how you determine the non-inferiority margin. There are, there is ICH GCP has several pages on how you do that, etc., etc. So it's and there are conventions, right? It depends on the confidence intervals of the previous estimates that are available, and you try to be as conservative as possible. So that is a 2-hour lecture which I told you in 30 seconds on how you determine the non-inferiority margin. Okay, right. So now in your active control trial, you have two questions. Is the new treatment better than, or is it not inferior to the best available treatment? Then you have design options. You have superiority, equivalence, and non-inferiority. Right, sorry, before that, let me go back. Right, so as I told you, if you believe your new treatment is better than the previous one with reasonable amount of confidence, you design a superiority. Right, now equivalence means both bounds of your confidence interval comes within the non-inferiority margin, which is already very narrow. When do you get a very narrow confidence interval? Large sample size and large number of events. Okay, and by events, let me first tell you, you could be measuring tumor size. It need not be survival. It need not be any other hard outcome, right? So it has to be, so you need a large sample together. So equivalent, please don't confuse with bioequivalent studies, which is done on a pharmaceutical product to compare it with the previous best available, right? That has to be between 80 and 125%. That is bioequivalence, that is blood levels. We are talking clinical outcomes here. So if it is soft outcomes, you can get away with equivalence, but if it is hard clinical endpoints, as Dave Sackett, the father of evidence-based medicine, in one of his books, he said you need an infinitely large number of events to establish equivalence. That is not feasible. Therefore, we choose the next best, which is non-inferiority, and that is acceptable. There are plenty of studies you will look at which tells you about non-inferiority. Okay, factorial designs, evaluating 2 or more treatments within a single RCT. This is not parallel arm, multiple arms. This is within one trial, and there are differences. So I'll just make this one statement and stop, which is it is different from parallel designs, multiple arm parallel designs. So factorial, and we expect that the treatments act independently. We can also study the interaction of 2 or more treatments, and this is efficient in terms of cost and time. So please do look up and be a little more familiar with factorial designs. So this is cardiology, and using this, I want to segue into oncology trial. So this is a classic large trial where we looked at a low molecular weight heparin in patients who had acute myocardial infarction, and the outcomes were mortality, reinfarction, and strokes. This is the first trial that I worked on in India here. We started this in the year 2000, and then we took about 5 years to complete this. We recruited 8,000 patients from 65 centers. The first big deep dive, as you like to call it, into clinical trials. Huge amount of learning. This is what we do. So this is a partial factorial design. So 20,000 people from 5 different countries, about 5,000 people were in one arm only, and 15,500 in the full factorial design. And this is a parallel arm, right? We published this in the JAMA in 2005. And these are our 7,000 odd patients, low molecular weight and placebo. Look at how well balanced they are. All confounders that we collected are so nicely balanced. Those we didn't collect also were balanced. So age 58.9, 59. Anything else? Diabetes, let us say 17.2%, 17.1%. Anything else? Let's take systolic blood pressure 127, and the standard deviation is also the same, 127 and 26. So this is the beauty of randomization. You are able to achieve this because you have these large numbers. All right? If you don't have large numbers, then we have to stratify. Statisticians don't like stratification. Okay, so better to have large numbers. Okay, so these were our outcomes at 7 days in Reviparin and placebo. So we had, these are the numbers randomized. So 9.6% had death, MI, or stroke, any one of them. It's a composite endpoint, and 11% here. Is this difference statistically significant? We did survival analysis, Kaplan-Meier curve, Cox proportional hazards, which all of you have read many times in oncology, and we computed a hazard ratio and its 95% confidence interval. So there's a 13% reduction in death, MI, or stroke in the Reviparin arm compared to the placebo arm. Look at the confidence interval, and therefore it is statistically significant. This is our conclusion, right? These kind of trials are challenging, particularly these days in oncology. And therefore, this is a Kaplan-Meier curve, the same thing. Let's briefly look at phase 2 designs, and a lot of what Dr. Shankar mentioned in the morning, I'll be briefly mentioning without any statistical notations. Okay, just to keep things simple for us. Now, it is really important for us. So what is the goal of phase 2 trials? What do we want to do? Phase 1, what do we do? Absolutely. In all phases, we do safety. We never stop doing safety. But in phase 1, we want to see what are the best dose I can give humans that they can tolerate, right? And we go on and on. And oncology is one of those branches where straight away we give it to patients, right? That's something that we teach you in pharmacology, second year in medicine, right? Onco drugs, okay? So we want to identify the right dose, and we want to improve the probability of success in confirmatory trials. So in phase 2A, we do non-comparative studies, generally speaking, okay? And we want to estimate the maximum tolerated dose so that we can use it either in phase 2B or straight away in phase 3. In 2B, it is usually randomized, right? Definitely we look at safety, but we also want to see, can we bring in some efficient designs to look at superiority itself, so that when we do the phase 3 trial, we are fairly clear as to how to design it. So this is an overview of how we do phase 2 trial designs. Now, you know this well, but for the sake of completion, let me tell you, with recent cancer trials, with newer therapies coming, there are a whole lot of challenges. I mean, I was reviewing the literature because oncology is not my specialty. Every year there is so much of improvement, so much, and huge amount of learning. So I must thank you people for my learning in oncology and in these trials. So in immuno-oncology therapies, or IO therapies as they say, preclinical data is not going to help us with phase 1. Because the immune response in animals is very different from humans, and within humans there is so much of variation as well. It's not like a classic other drug, right? So there is heterogeneity across patient populations, right? And the identification of optimal dose is always a challenge, right? And also, not all patients respond to the novel therapy. It's challenging to conclude a clear relationship between doses and safety and efficacy. So these trials are always challenging for us to do. Next, traditional dose finding designs in oncology, the first in human trials, I mentioned this earlier, gives us 2 bits of information: the maximum tolerated dose and the RP2D, as they call it, the recommended phase 2 dose. What is the dose I must carry to phase 2? Okay, the primary endpoint is the
dose DLT as we call it, the dose limiting toxicity. Now our dose for the phase 2 will be either this first dose or it should be lower than the MTD, right? They usually start lower and then they see based on patient response. Right. Now, the traditional dose finding designs in oncology are two categories. One, we have the model assisted. Dr. Shankar mentioned this in the morning, wherein we use statistical models to decide the dose before the trial starts. Okay. Then, so the types we have is modified toxicity, probability interval design, then the Boyne design. He mentioned it multiple times. He showed that software as well is available, and then the keyboard design. Then we also have the model-based design. So this is model-assisted. The model-based designs are continual reassessment. As the trial is ongoing, you reassess and also do the Bayesian logistic regression model, looking at prior data that is available using Bayesian statistical techniques. So clearly, all of this, we need to work with a statistician from day one. Further unique challenges in immuno-oncology is the immune-related adverse events cannot fully predict the dose limiting toxicity. It happens in some people, it does not happen in the other people. So what do I do at a population level? So the other designs that we use, he mentioned it again this morning, time to event continual reassessment, CRM design here, and the time to event Bayesian optimal interval, the tight Boyne. He mentioned this as well in the morning along with the notations. From the back, I couldn't see it too well. And also his slide was a little small, right? Yeah, I think within that itself, so some setting, okay, anyways. So because all those notations we couldn't make out from the back. Now there are more challenges. In cell therapy, now this is not challenge with design, it's a challenge with a product now. In cell therapy, you know how difficult it is to get CAR T cells, right? Although now this is it actually became major news, the CAR T cells that IIT Bombay did. In fact, the day before I came here, I was there for a program at IIT Bombay and met some of those people. There's a new facility they have built up. In fact, one gentleman actually said, oh, sorry, not one gentleman, you know him, Dr. Pramesh. he was the chief guest there. Why am I, you people know him very well. So Dr. Pramesh was telling there are more biomedical researchers in IIT Mumbai than in the medical hospitals in the city itself. Amazing. There are 300 PhDs going on in biomedical research in IIT Mumbai. 300 PhDs at the moment. So anyway, it's amazing. So it's fantastic. So cell therapy, usually very limited doses to be explored and also limited number of patients. So the amount of material you have and the number of patients, so you need to bring in lot of efficiency. So dose finding must shift from maximum tolerated dose to, it's called OBD now, optimum biological dose, right? So we need to look at the highest efficacy probability while inducing the toxicity. I'll conclude with a little bit on adaptive trial designs. What does adaptive trial designs mean as a concept and how is it different from other designs? So we use the results that are accumulating in the trial to modify how the trial is proceeding, right? The important thing, and I underlined it, the rules are pre-specified, it's written in advance. It's written, okay? And adaptive trial designs, and I asked you this question, is often more efficient, is more informative, and more ethical. Can one of you tell me how can it be more ethical? Efficient, fine. Informative, fine. How is it more ethical? How many people wrote yes to that question? Is it more ethical? Okay, how many people wrote no, it is not ethical? Hands up, please. How many people wrote IDK then? Very good. How many people did not bring your hands now? So if you add up all the three, it doesn't include the number of hands here. Yeah, no, never mind. Okay, so you want, yes?
Be adapted, more patients will get the treatment.
So if we don't adapt, so we just go ahead with the same treatment throughout the course of the patient. Now, if we adapt, we curtail the treatment according to the response. So we are exposing to the appropriate treatment to the appropriate response and not exposing to over treatment. And
waiting for one word which did not come. You're right. You're almost there. Like you ran the marathon, you came inside the stadium, instead of completing 2 more rounds, you sat down. Okay, so it's more ethical because harmful treatments are stopped early, right? And potentially useful treatments are given a better chance. There's a colloquial terminology for that: play the winner strategy. What is winning, give it more and more chance. Okay, so that is why it is more ethical. You can do it faster, lesser money. Okay, so keep in mind, whenever we talk ethics, it is we are looking at the patient, the individuals. Particularly, we're looking at harm. That is where ethics come. Everything else, efficient, informative. Pharma companies love this because they can save a lot of money and we can bring out the product earlier, which is good for everybody. Okay, all right. So often better use of time and money, and might require fewer participants. All of this is wonderful for adaptive trials. So adaptive trials initially was only in phase 1, early phase 2, and they were trying all of that. Now you can do it across all phases, from early phase right up to confirmatory trials. We can do adaptive designs, and I'll give you an example. So here is a traditional fixed sample design. You design, you conduct, you analyze, report. Worked, did not work. Here, the adaptive design, you conduct, but you review the data. You go backwards now. Go ahead, show me the data now. Okay, then you adapt, then you conduct. But the key point over here is this review is done based on pre-specified rules. If this happens, you can only do this. If that happens, you can only do that, right? So it's not making adjustments, so that you want to show that your product works. Then we analyze, and this can happen multiple times. Okay, of course, you have specialists doing interim analysis, and they will show you how it works, and statistically all the adjustments will be made. Okay, types of adaptive designs. Look at the numbers. There are 2 pages of this: biomarker to randomization to dose ranging to seamless phase 1 and 2 and seamless phase 2 and 3. Then you also have continuous CRM. I mentioned it earlier. Then you have the group sequential, you have sample size re-estimation, you have the MAMS, it's called multi-arm, multi-stage. I will show you an example, and I will show you an example of the population enrichment now. So this is, again, making it a little more ethical. That means people who are responding, we enrich the trial. So we increase the power of the trial without increasing either the sample size or the duration of follow-up. Those were the traditional methods by which we increase the power of the trial. But here we are able to do it with the same number. In fact, we're reducing the number of participants because we are stopping treatments. Okay, right. So here is a 2-stage population enrichment design, and this is actually from the New England Journal. It's a general medical journal, and written by actually Deepak Bhatt, who was at that time he's a cardiologist from India, obviously. And he was at Harvard University at that time. Now he's moved. So here is the 2-stage population enrichment design. So while starting itself, you stratify the population based on certain characteristics. Then within that stratification, you randomize, equal allocation, randomize, equal allocation. Then you do interim analysis, and you look at the results. And then again, here you look at the results. Then in one arm, if there's no response, you stop for futility. Is not working. Stop it. Next, there is some signal is there, continue it. Oh yeah, this is interesting signal, continue. Okay, I'm not giving you all the details. And then you finally do the analysis. 2-stage population enrichment. So people who are responding, and also biomarker response adaptive is also a similar kind of a philosophy that is there in the design. Okay, so this is again something new, or relatively new, designs with master protocols. And you have one product, and then you want to do multiple studies, you do all that with one protocol. One protocol, you can do many trials, different patients, and you have a shared control group. Very efficient. Okay. Types, you have basket trials where you have one investigational product, different investigations. Different indications, different types of cancers. Right. Second, you have an umbrella trial where there are multiple investigations for one indication. Okay, multiple different studies can be done. Then you have what's called a platform trial, which combines these two: multiple treatments, one indication, in a perpetual manner. You can continue on and on. Results come, continue. Results come, continue, and keep publishing that. Trial is still ongoing, but results are coming out. Okay, different things. So here are the MAMS, the multi-arm multi-stage platform RCT, to speed up evaluation of new treatments, many treatments compared against a common control arm, and we can do pair-wise comparison in several stages. Okay, this one example. Let's look at this diagram here. This is a traditional approach. Phase 1, you're evaluating 4 different treatments. Phase 2, you have 3 different treatments. T2 did not work so well. So how many trials are here now? Phase 1, 4 trials. Phase 2, we have 4 trials. Phase 3, we have 3 trials. So totally 7 trials we've done. Okay, and then we come back and say that, treatment 4 kind of works. All this is not useful. Can we modify this? Okay, this is the multi-arm, multi-stage or seamless phase 2 and 3, right? Control continues, the same control. You have treatment 1, it continues. Treatment 2, you stop. Treatment 3, you stop here. Treatment 4, you stop here. Or you continue on. So in one trial, you're able to have so many comparisons simultaneously almost. Okay, so brings in a lot of efficiency. By the way, trials are very, very, very expensive, complex, ethical issues. It's not easy to do. It's easy to actually design. Dr. Santam was right. Doing observational studies is very easy to get it wrong. Very easy to make mistakes and to cover it up, whatever, right? Trials are easier to design, but more complex to conduct. Okay, because of all these logistics. Okay, friends, sequential multi-arm, this is the last one I want to tell you. I can go on and on, there's so many things. SMART, it's called sequential multiple assignment randomized trials. So in clinical settings, patients treated using sequentially and individually tailored approach for each patient. So there's a dynamic treatment regimen based on the response, increase the dose, reduce the dose for the same patient. In fact, that's what happens in clinical practice, isn't it? That's what, and can we bring that into the trial realm itself? Right, pre-specified decision rules, and then in SMART for dynamic treatment regimens, in addition to standard multi-arm trials, we have multiple stages of randomization. Those who responded, you randomize them again into higher dose and a little increased dose. Okay, something like that we can move on. So here are the Stampede trial, which became very famous recently. This is in prostate cancer. So 2006 they started. Look at the number of arms, 12 different arms, and it's still ongoing. And then multiple publications come out. So I wanted to share this with you, and I don't want to tell you all these different treatments that they tried out. And just to let you know, this is a multi-group, multi-stage platform trial protocol investigating additional therapy when patients are going to start ADT in men with prostate cancer. Okay, and look at the kinds of prostate cancer: newly diagnosed, locally advanced or metastatic, relapsing disease, poor prognosis. Put everybody there, and let's try out. Put everybody there, and that's what real life is, isn't it? We can't be doing one trial in each of these people, right? And this is published in the NEJM. This part, okay, abiraterone, one of the arms was published recently, or not recently, sometime back in the NEJM. They assessed the effect of this drug along with prednisolone, and in men who were starting ADT therapy, and then they used the multi-group, multi-stage trial design. So let me summarize this for you. So now we know why RCT is a gold standard for evaluating any treatments. Please do not make any comments about efficacy of any treatment if it is not a properly conducted RCT. People are still doing it. There are some smaller pharma companies that are still, they come around and collect some, some post-marketing data, something they collect, and then they go and it will not get published in journals. It will get published in, fancy, pamphlets. They'll come and give it to you. So people are still doing that, unfortunately. So only an RCT. So randomization ensures a balance of prognosis, concealment of allocation and blinding, important design considerations to ensure that you have a high quality trial. Then non-inferiority trials are increasing because we have treatments pretty much for everything these days. Factorial design, several advantages. Cluster, I didn't speak to you about. Adaptive and other novel designs brings in efficiency, time, money, and patient safety. We have unique challenges in cancer trials, and you have several design options that bring in efficiency, and things are still evolving very rapidly in oncology, and all of you are super lucky to be part of this course. And the best part of the course is in the afternoon, actually, right, where you sit and develop. So I hope you found this useful and insightful for you to go ahead and design your own studies. I didn't want to give you anything hi-fi. So this is what I wanted to share with you. So thank you very much for your patient hearing.
So thank you, Dr. Dennis. That was almost like a one-stop solution for phase 2 clinical trials. So from the simplest to the most complex MAMS designs, including Stampede. So I don't think the audience could have asked for more. Um, but despite that, if you have any questions, Dr. Dennis is here to answer. So may I have one or two questions from the floor, please? Please. You may want to come here because the online audience also should hear you. Yeah, that's
Sir,
better.
whether adaptive trial can also be used in the single arm study? You had shown it in the randomization trial.
So firstly, a thought about single arm studies. You get very little information about single arm studies, right? Because you don't have so your only comparator is time before and after, right? So yeah, you can. I'm not saying you can't do single arm studies, but it's always better to do parallel studies, and then you have a comparator in real time. And one other thing, please try and avoid is historical controls. People still do that. They still try to maneuver huge limitations with that. After all the trouble you've taken, it's not going to be much value. I hope I told you something which you did not even ask, so I hope that was useful.
Yeah, one at the back.
Hello. Does immunotherapy-based trials require modification in phase 1 study? Similar way, it is require any changes in while conducting in phase 2 studies?
Okay, I'm not an expert in that part. I'll give you methodology, right? What are the challenges with immuno-oncology studies? We discussed it already. I will not repeat it. Okay, so in phase 1, you're still trying. So that's why I went through that little bit of detail of what you achieve with phase 1, particularly in cancer studies. You first of all give it straight away to patients. So immune therapy is so different, right? You cannot extrapolate from preclinical to clinical or first in human. You have that 1/10 dose. Dr. Shankar actually mentioned it, right? You asked that question. He said 1/10, you start with that. It's safe, etc. How the patient's going to respond? So you may have to have multiple sequences before you begin to see even toxicity if 1/10 is too less, right? 1/10 can also be. So you cannot really, say how long your phase 1 could be, right? The same things would apply later on is my basic understanding, but do you want to add to that, Dr. Vikram?
Yeah, but in terms of adaptation, I think that's what Dr. Anberson was asking, whether, phase 2 single, immunotherapy trials, whether there's adaptation possible. See, actually, adaptation happens at various levels, okay? So you can have adaptation in sample size, so where you can do a sample size re-estimation. Adaptation in allocation ratio, like for example, you start with 1:1, maybe you say that, okay, midway through the trial, you change over to 2:1. So allocation in the treatment allocation, adaptation in the treatment allocation, like for example, pick the winner that Dr. Dennis was talking about. So you think one is not working, so you drop it early, and then put more patients on the treatment that are working better. So these are the various adaptive designs. So it is not, you cannot straitjacket adaptive designs into any one particular type. It's not just the number of trial arms that you are adapting. Adaptation can happen at various levels, at various stages. So it's a very versatile design, and that way immunotherapy are also amenable for adaptive trial designs. I don't know whether I answered that question properly.
Just give a okay, just ask that phase 2 and phase 3, is it?
Yes.
Okay, just ask
So
your question.
when we design a trial, when we design for phase 2 trial, or how to choose between phase 2, or we plan for phase 2 and combination of phase 3?
Okay, so
In which
what
area
I understood
specifically?
is, okay, you want to evaluate a treatment. Is this actually phase 2 or phase 3, or do I start with phase 2 and go to phase 3? Is that something what your
Yes,
question is? Okay, so usually we don't, I mean, as academics, I'm addressing you all as academics. If a bunch of pharmaceutical, scientists were sitting here, it's very different because for them, it's very rigorous. And for them, it is watertight because they have to say this is phase 2A, go to the regulator, get approval, then only do this, etc. Right? So for now, so again, Anbarasan, right? Right, Dr. Anbarasan. So you look at what are the purpose of phase 2 and phase 3 quickly. Phase 2, we are traditionally, and even in oncology, you're trying to look at the efficacy of this drug for the first time. Phase 1 is only safety. You're looking at efficacy. Simple way, in phase 2A, you're looking at, it can be a single arm, like you said, okay, before, after, and then see what, and it can be non-comparative. Just give it to some people and see what you're getting. And the goal of that is to tell you what is the dose I can use for the confirmatory trial. Now phase 2b, you do a comparison. You're also using all these efficient designs. Very briefly, I probably gave you less than half of all the designs that are there in the time that was available, right? You're trying to use these designs, efficient designs, to see, can I look at efficacy here itself? Okay. Now, based on that, you cannot say this can be used everywhere. Now, some of the trials in oncology that I understand have stopped with phase 2b. They are not able to get that many patients, or sometimes that's why they say, let's add a few more patients and call it seamless phase 2 and 3, seamless 2, 3. So they use the same patients. It's not traditionally, you stopped, you published, and then you have a rationale for using the dose and the protocol in phase 3. But here you do it seamlessly, and you want, and that's where master protocols come.
So how to decide that whether we want to, matlab, what factors will aid in those decisions?
Of moving from phase 2
so
to
how
3?
to
The
design,
question is,
because
you know,
everything we plan
Yes.
before starting the trial.
His question is whether, how do you decide whether I should just do a standalone phase 2 or whether I should do a phase 2 going into phase 3? Uh,
Yes.
So do you have those issues in academia is what I'm asking. Right. So for us now, and of course, theoretical, knowledge is important, right? So for us, as academics, we want an answer now with whatever resources we have. And the biggest resource constraint is time, not even money. Now, we have very little time for us, and saying other resources as well. So what is the research question we have? Are we able to answer that in a phase 2b? If we can answer it, we can as well stop there. Right? If not, we move on, we add more patients and go on to phase. Or there are two ways. Okay, so your question partly could be, do I do a seamless 2, 3, or do I stop at 2 and then do 3? Correct? Okay, so I think that really depends on the hypothesis, the resources. To the best of my knowledge, please add or correct what I'm saying. So therefore, if you have a clear enough answer and you want to stop there, you can stop there. If you don't have a clear enough answer, then you can go to phase 3. And this is something that you need to have pre-specified rules to the best of my knowledge. You want to add to that?
Yeah, correct, absolutely. So phase 2 going into phase 3 is a more recent development in the last 1.5 decades. But before that, it was the traditional, development paradigm was you complete your phase 2 and then go to phase 3. But now, time is of essence. Like for example, so all the trials are getting more and more efficient. So what do we mean by efficient? Whether you can answer a given question with fewer number of patients in a shorter period of time. That is the efficiency of a clinical trial. And therefore, even the phase 1 trials are moving from 3+3 design, which are traditional, to something like BOIN or whatever, which are efficient because they will get to the MTD dose in a much shorter time period of time with much fewer patients. So that way, we are evolving towards more and more efficient trials. So the answer to your question is, there is nothing to say that you have to do a phase 2 and then follow it up a phase 3. You can pretty much design phase 2 going to phase 3 for almost every drug, because there is a decision rule even in that. So at the end of phase 2 component of the trial, there is a decision rule whether you want to go forward or not. So it gives the same readout as a standalone phase 2 followed by a standalone phase 3. So I think that's the reason why more and more you will see that people are designing phase 2 going into phase 3 rather than standalone phase 2 clinical trials.
So I think the key point over there is my first line in the adaptive design slides, which is based on pre-specified rules. So you write that well in advance, and then you go ahead. Yeah?
But of course, if you have too much concerns about the safety of a molecule, you may want to design a standalone phase 2 because you want to be absolutely certain that the safety aspect is taken care of before you design a confirmatory phase 3 clinical trial. But that apart, pretty much anything can be designed as a phase 2 going into phase 3.
Thank you, sir.
Okay.
So as he was asking about immunotherapy adaptive trial, so there have been actually a couple of studies in cancer. So what they have used is that before surgery, they have given immunotherapy. Now, if at surgery you find a complete response, you don't go for any further immunotherapy. And if you don't find a complete response, you can go for further immunotherapy.
Fair enough. So, yeah, I think, I'm sure there will be many questions, and Dr. Dennis is definitely available with us for the next 2 days. So you can pick his brains, during coffee breaks, tea breaks, lunch breaks, and so on. And in the interest of time, I think we have to move ahead. And in fact, we are already, 20 minutes behind the clock. So we'll break for a quick tea. And then I want you all to get back here in 10 minutes flat. And for the audience, online audience also, Once again, as Dr. Dennis said, get up, stretch, take deep breaths, and grab a cup of coffee and get back in 10 minutes time. Thank you. Good morning, everyone. Welcome back after the short tea break. And now we are moving ahead with the workshop. The next talk will be delivered by Dr. Amit Dutt on diagnostic advances in research. And he'll be talking to us about NGS, circulating tumor DNA, liquid biopsy, biomarker discovery, etc. And Dr. Amit Dutt, it gives me great pleasure to introduce the speaker, a good friend of mine. He was with us in Tata Memorial Hospital, in Tata Memorial Center, ACTREC, till very recently. He was a scientific officer here. And his primary interest was to look at somatic genetics of human cancer and help develop the next generation of effective targeted therapies to improve treatment of cancer patients. And more recently, he moved to Delhi, where he became a principal investigator and a professor in the Delhi University South Campus. So, I have known him for the last 15 years, and his work on cancer genetics and targeted therapies is really phenomenal. And I'm pretty sure you will really enjoy this lecture. And with that small note, I would like to invite Dr. Amit Dutt to deliver his talk. Welcome, Amit.
Thank you.
Yeah, we can hear you, Amit.
Yes, great. So thanks, Vikram. It's always a pleasure. It's always been a pleasure, and so shall it always to speak at or for friends like you. So yes, as what Vikram has I'm a basic scientist. I have been a faculty at ACTREC, a particularly center for the last 2 months, and very recently I have moved on to the Department of Genetics at the South Campus. But the work that was happening and doing at ACTREC shall continue to pursue the same plan. So, as Dr. Vikram has said, with regards to diagnostic advances, primarily focus on CTP. I'll give you a glimpse of it, but I will be restricting it to my research as well and how to apply the same in advancing the understanding. So I will be giving a basic biologist perspective to you with regards to the biomarker and its discovery using NGS platform. So let's start from the basics. Let's start breaking with regards to understanding of the research is discovering essentially it's found that it is measurable entity, an entity which could be actually identified or any characteristic feature. That means particularly for pathological process that can be assayed. And when it comes down to the discovery, it is always associated with some intended use. And these intended use essentially used in the diagnosis or prognosis or in the prediction, in which case it would be a and at the same time monitoring. So when such would be the intended use of biomarker, what essentially we have to privileging that we taking up the is something that kind of like fits into the city. And that comes to my mind as the first molecule which will be used definition of biomarker. And that's where I'm going to but before getting to CTA, I think that before the back understanding is strong, inspired the efforts of the research lab and how we can make this more kind of like move to the clinics. So all the projects, they all generally start with very detailed. It has detailed planning wherein the researchers working in the laboratory always manner. And it goes on to the my laboratory uses an NGS platform, but that's not the only way of doing organ mapping research. There are different ways that we can do and discover. Now, this is the moving on. Where we will explore it. We talk to biologists in general, biologists will talk about the fact they have really huge discovery, and when they have made a discovery, they have also validated the discovery in different clinical samples, in different settings. But that's exactly where we kind of like holds the bar. What is the most relevant bar, and what is where we like look beyond scope of and need to investigate is to go into where to be where to be move on to the next phase into the asset development and clinical validation, which is where the most of the emphasis lies upon the process. So being a company or working around with connections with the and so much and how do we identify. That's how actor leads the way or brings something from the basics, making that discovery by people like me, and then in collaboration, taking it beyond. And we have to be very successful in doing so. Looking at the same thing into more quantitative manner, slightly in a different perspective. This is what is shown on the slide, is that this is what the phase that I was talking about where we kind of where basic biologists tools cover about where numbers of biologists are identified day in and day out. But if you would see the number of samples that will be used for studies are relatively much lower. And the actual drugs actually talked about previous slide, which is essentially the slide is taken from and this is for the IAC line. This is where the one of the most important of the where where the data falls and where things fall apart because of the variability that arises. So essentially, what emphasis has needs to be emphasized upon is that to increase the signal and lower down the noise. And these are not two that they are very much capable to do each other, and that can be done by people like you and I, all clinicians and pharmacologists and basic biologists come together and bringing it. So it's not something over one factor kind of doing. So as what I said earlier, that CTT integrated tools for fits into that criteria very well. So let us take us two, three slides to go back to the basics that what exactly the CPT is, where it is coming from, and how it is being used in the work that we are doing, and how we are bringing it back to the clinics. So essentially, what historically what has been done, and so it been done well, is the tumor biopsy, and that's what we have um, uh, understood so well that these solid tumors, they are not so clonal. Essentially, a primary tumor would have several different subtypes, and whatever biopsy that you take would not be representative of the complexity of the genetic alterations or rapid clinical alterations in down to the metastasis, that which is one of the most important treatment for cancer that we addressed, is that in metastasis, how many biopsies could we take? How many sites could we address? So one of the emerging answers to this is coming out is the liquid biopsy. And essentially in liquid biopsy, what it is being intended is that in liquid biopsy, which is so less invasive, uh, the the nucleic acid, which is being released by necrosis or necrosis or different biological process by and taking that blood, or it's not just the blood, we can go by the fluid and take it further. So, but this is not that simple or straightforward. There is very because it's full of nuances. Given that the blood is where there is an amalgamation of all of these kind of molecules. So, for example, the blood will have the nucleic acids not only from the tumor cells, but it will have from all the normal cells as well. In fact, the very the proportion of the DNA that has been contributed by the tumor cell, which is called as the ctDNA, the circulating tumor DNA, is significantly much lower as compared to the component that comes out from the healthy cells. Now, to make the distinction between them is where all the genius lies. That how would you be able to do that? Wherein all the different technology can come to your aid to do as well. As what I said, it doesn't have to be blood only. It could be urine, it could be medical time fluid, it could be fluid fluid, saliva, any liquid where free DNA is spread. So in brief, what it actually means is that ctDNA, the blood is full of these kind of like DNA from healthy cells, which is called as cell-free DNA. And ctDNA is a subset, a smaller quantity, less liquid form in those. Which is called as ctDNA. ctDNA. By different and why it is important to assess that what tactic kind of technique is that it gives you, because it comes from the tumor, it allows you to assess several different kind of alterations that is happening or that is representing the tumor. And now with more and more understanding that it's not just the genetic alterations, but also the epigenetic alterations, such as the chemical modification of DNA, the methylation of ctDNA, which is way too far more much. I would go on to use the word easier, way too far more easier to define than to look for these genetic alterations from the ctDNA. And based on that methylation pattern, now a lot of emerging studies are that they are able to assess, quantitate, and also use it as a QC for the ctDNA present in the blood as to discern it from the cell-free DNA, that is the DNA which is arising from non-tumor. So in particular, I don't need to take details of it, but I just want to tell you that this research of ctDNA and its finding is not something either having and they all cell-free there, not something as early as in 1948. However, now about like onwards, you can see that there has been significant FDA approval where longitudinal monitoring of the disease, such as the emergence of the ctDNA in the blood, has been approved for the process and monitoring. So ctDNA essentially allows you, as what the earlier biomarker technician that I started around with, and so it's intended to, it can be used for early detection, it can be used for monitoring, it fits very well into the criteria of this and monitoring alarms like monitor frequencies, and most importantly, it is also that emergence, re-emergence, see that is the minimal see assessment is something where TPA is coming down to be a very important milestone. People like basic biologists are also getting into CPA, not just because of its prognostic and diagnostic value, but also it is turned out to be a good component for making some major significant discovery. And I will allude to that with two different examples from my laboratory in the next slide. This is to show you that how the field is emerging. This is the bar where you will be essentially performing the radio imaging scan of patient who has received the treatment and who is stable, who have responded to the treatment, and the disease burden has been decreasing. So for image scanning to identify or detect the emergence of the disease in the timeline, this is specifically shown for the breast cancer with regard to the ER positive patients. For the timeline, when it really shows the emergence or re-emergence of the disease is significantly different by radio imaging as well we will compare it with the timeline for the detection of the ctDNA in the blood. So the ctDNA in the blood happens much early on, and that allows you much better window period to restage the tumor of these patients and then able to apply regimen early on as when the disease has represented itself in an aggressive manner. So this is something which is a very important aspect of ctDNA that is really taking the world head on. And so the next few slides, what I would do is that what are we doing around with the ctDNA and how the work in collaboration with the clinicians here at Comparative is significantly advancing. So here is a work done with Dr. Kumar Prakash, who's talking yesterday with regards to big ideas. So he is a man of big ideas, and this is one of the big ideas. And what's happening here is that there are 26 patients who are, I'm not taking into the details of it because you are proud at this point, glad that kind of introduction. And also due to the diagnostic, we can go straight on. So here is a lung cancer patients who are all GFR positive. And these GFR mutations are drug sensitive mutations who activate patients of GFR. And all received Jefferson or even osimertinib in response to the diagnosis of GFR mutation. So what was done by Dr. Kumar is that longitudinally we followed up this patient and play and the whole team just recently heard by Dr. Jeff Arthur, I guess, a very core and a capable member of the team who has the big now longitudinal collections of all these patients were collected, and it was assessed that what additional information the ctDNA would allow us to inform with regards to the disease biology of these patients whom we had the information that they were EGFR mutation positive. So let's see what happens in there. So this is the representation of the same patients of the same study, where the patients who were initially sensitively responded. In fact, we had a different variants of response. There were early responders, late responders, early resistant, late resistant, and intermediate as well, relapse as well. But this is what is represented. So there is a mixed bag of patients. Patients who responded, where the relapse was delayed, and their patients whose relapse was early on. So that was a mixed group of patients, and we went ahead and performed the liquid biopsy. We used in collaboration with One Cell Diagnostics in Pune. They have their own in-house developed panel, which is an called an onco index gene panel, and essentially this is a 600 gene panel. 600 gene panel. There will be the 200 copies and selection of medical patients that are going to be collected, and they will see objective bypass. So my laboratory, having an in-house informatic pipeline, we analyzed the data and we went ahead and we looked at the first aspect of it is the clonal analysis that what comes out of these studies. First thing first, you always want to, as what was shown earlier as well, you always want to do the QC. So here are the genotype information of each for this patient, as what knew that these patients they were part of these mutations in each GFR. When we did the liquid biopsy, we were wanting to match that RB missing out, or we are able to find, and we found that several of these patients, most of these patients had matching GFR mutation, and a few of them had an emergent B790 mutation by liquid biopsy, which essentially were missed by the tumor biopsies. But something very interesting when taking a big stories in a mass, when we presented, here is a patient, and here are the different clones of the patient, and this is how the going through the collection, the disease is progressing. What we essentially kind of like did, finally the work of the student with Supriya and we job, Ganesh Nayangar, student. So what they have done, they performed global analysis for and they found a significant change at the time point of the response and the relapse. The detailed fish plots has not been shown here, but because I didn't want to divert your attention with the fancy fish plots, I wanted to keep it as raw as possible. What I want to draw your attention to, what Supriya and the team has found, is that something very interesting. So there is a clone as the disease progresses, which is called as the founder clone. And the founder clone is defined by the clone, which has the set of mutation, which forms the stem of this disease. And they found that there are significant alterations in gene that they initially found that initial idea was that those were tumor suppressor genes. And this went on from patient to patient, that they found that in the founder clone, there was a predominance of alterations in the there were mutations in the oncogene, but then there were conservation of the mutation. That is the mutations which were present at the baseline, and these mutations were selected for as the disease was progressing longitudinally. And this went on, right, folks? I'm not. This has been done for all the clinical examples, and very elegant fish plots allows you to look at how these clones are evolving and how the clones which are the founder clones that remains constant, they are where there is a conservation of class of alterations in class of genes which are primarily tumor suppressor genes. So what essentially it means is that at this point of time, this study is allowing us to understand disease biology, that at the time of presentation of the initial diagnosis, while we are looking at we are also looking at the tumor suppressor gene. We will be able to, that will be more of an indicative of the prognosis of the disease, that who are the patients that they are 80% are going to early relapse, and who are the patients who are going to be late relapse based on the study. And this study is presently it's being written up. It's an exhaustive study that the liquid biopsy across 240 samples that has been pursued. Another study that is more relevant on this topic. And so as what I said, I mean, the implication of this, I mean, this is where the basic researchers who have otherwise stopped. But now, with Dr. Kumar on being involved, the implication of this goes straight on to the minutes where when the initial analysis of the particular reports of the patients are being taken, we not only take into the activating alterations, but also look at the cooperative tumor suppressor genes. And we are able to define that as cooperative tumor suppressor genes when they occur, they have significant altered prognosis, and accordingly, the treatment regimen that is to be given to the patient needs to be more aggressive. And at the same time, patients who could be spared of an aggressive treatment can be very well stratified and identified. And another study that I wanted to talk about, we are, this is the study is under review, and this is being done in Dr. Vikram Koda in collaboration with is that we were and also you are well aware of the Atora trial, introducing this Atora trial, where essentially in lung cancer, at the early stage, when monitoring was being done for the ctDNA, and they found that uh, uh, that if you are giving them an osimertinib being offered to the patient once a day, there was a significant delay in the reactive, so in the adjuvant setting at early stage. So this is the only evidence for giving osimertinib at an early stage of lung cancer adjuvant setting. But the problem was, the impediment was that this osimertinib was being offered daily and for a significant period of time, as what you're aware, that the cost of this will be so prohibitive with more than 2 lakh rupees per month, as what it comes down to. So a postdoc in the lab, Dr. Ashwin Gupta, that went down to the literature, he made a finding. What he found is that while everyone's the first generation drug has a much lower half-life in blood, osimertinib could be there in the blood for something as 21 days above its IC50 value. So the question that we wanted to ask is that osimertinib, which is being maintained and which is for 21 days, would it allow us to do a altered dosing? We really need to do a single dose every day, given that it is there at its IC50 level, and much higher than the IC50 level based on the literature beyond 28 days. So, what we have is very cautious about. According to him, this is literature. We need to do our own study, and we need to we have to perform and see that what exactly is the half-life of this drug in, let us start with athletes. So along with the data, we were able to do the study wherein the drug was offered possibility as well as to the market. And some the broad cycle. Do they and when we altered, what do you back? Is that yes, what the literature about the today, we find that that at least by the day 7, if not the day before there, the day 2 as well, but at least by the day 7, the IC50, the concentration of osimertinib in the blood was significantly higher than 50. Great. Once we knew this, let us now go ahead and see if we could model the Atora trial experiment in mice, and if we would be able to give this mice osimertinib in the form of weekly dosing as compared to the single day dosing. So we went ahead and did the study. What we did is Dr. Ashwin Gupta, he established a tail-bearing mouse wherein lung bacterial lung cancer cell it's not likely which is sensitive to the TFR job that is they were given who was injected with the tail, and these mice were were given the drugs at different doses. So they were given in daily format and they were given in a weekly format. So here you would see that when the agglutinin was given in the daily format and the cells, they were luciferase stacks to improve and improve diabetes. So when we did this study, we found that when you give the agglutinin on a daily dosing basis, it works fine. The tumors which has been formed or the cells which are open to the lungs, they do not go ahead to form the tumors, do not go ahead the lung tumors, which is true with osimertinib as well. So the daily dosing, as with the Dora trial reports, we are able to modulate the mind and we show that if you give it on a daily basis, the cells which hold the lung do not go and form the lung tumors. However, when we do the weekly dosing, as what the hypothesis was that agglutinin at the lower half-life, when we were giving it like on a weekly basis, we see that that these cells not only hold on to the lung, they bend on the tumors. But the real story and the most exciting time for us that in the Boston today, which is where the Dora White talks about, is that when you give, and which is where our studies of the Dora had suggested that there in the blood for a period beyond, we found that that if you give on a weekly basis, even after day 18, there were no cells that would be, there were no cells that were no trace of tumor cells uh, uh, the lungs, which is suggested that osimertinib essentially need not be given on a daily basis, but can be given on a weekly basis, and if not weekly, at least bi-weekly, whatever that will that needs to be tested in the clinical trial. We hope that this is going to significantly bring down the cost from this moving amount to somewhere around like over a period of years for patients, which makes it that is 1/7 of the cost. And a clinical trial for this is being set up now with the data and with the validation agency of the victim data that we are all excited for the tool that instead of once a week, we could do it on a weekly basis. So such is the battle. These kind of like basic discoveries where we look for the biomarker and you could use the liquid biopsy and find the hypothesis that for a poor tumor specificity or by following up and looking for that whether the osimertinib need not be given on a daily basis but can be given weekly. So these are the several studies like that I could share about today. And the work that I've done today was primarily as Supriya Hai and Aniket Chaudhary, part of the this has been done in collaboration with Dr. With good part of it remains to be published, and we are hopeful to have this. Dr. Kumar Prakash and the support group has been very has been the strength and has been the strength of the study. And this study was done in collaboration with Diagnostics including. So with that, I bring in my talk.
So thank you very much, Amit. Excellent talk on the significance of translational research and how scientists can actually make a difference in translating bedside work to the clinics to the benefit of the patients. Because that is something which is not a very common understanding amongst many people here. So they think that clinical work has to be done by doctors, but here is an example where something done in the lab can actually get translated for the benefit of patients. So excellent work and excellent talk, Amit. Thank you very much. So if there are any questions, yeah, please.
So it was an excellent talk, Dr. Amit. My question is that, like you showed a slide on CA breast, where just circulating tumor cells comes before your actual clinical disease. So as a clinician, what should we worried about? Presence or absence of circulating tumor cells, or there is any exact quantification beyond which you can say that they will relapse early?
So yes, so this field is totally experimental. Um, what is happening right now with the answers for the CBT, there is a big roles platforms. So when the liquid biopsy comes out to be negative, for example, that's not always an indicator for that if that is truly reflective of the underlying hospital. And there could be several reasons. There could be several reasons that why a liquid biopsy has come out to be negative. So as a clinician, your question is absolutely spot on. And when you would want to implement this in clinical practice. So my answer to this is that this is an emerging and then this is something which is very promising as well. But hold on to some more time where things would become more defined, that we would be able to that the negative predictive value, for example, or the positive predictive value would be better for this, that would be better for them, so that we could adopt it into the clinical practice. At this point of time, even though there are approvals with some specific tests out there, it's the variability is still out there very much. That I personally that adopting into the clinical practice in a uniform manner is not yet good. This is more of a proof of concept, very more efforts with people like you and I working together would be able to help normalize and help standardize so that it can be more uniform.
Yeah, actually, we are developing a similar protocol on head and neck care. So that's what we are struggling with actually.
I'll be happy to talk to you because we have like something similar. In fact, at South Campus, we are primarily totally focused on the faculty and everything ensuring, and that's primarily we are taking the comprehensive genomic profiling in liquid biopsy that is to be done. So I'm happy to agnostic of the type.
Thank you. Thank you so much.
Hi, sir. So one question from me. So normally as clinicians, many times we want to screen anti-cancer drugs, not like drugs for cancer, let's say metformin or losartan, whether they have any impact on cancer. Is there any cell line or model which can help you to screen a lot of anti-cancer drugs at one point of a time, so that you know that probably these are the molecules which you could focus on in future for development or repurposing of these drugs as anti-cancer drugs?
So, Vijay, I mean, something very typical and classic about you is that you always think beyond. You always have things to look at. This is exactly the focus of research at the Broad Institute of Harvard and MIT, like Broad Institute, where I perform my postdoc studies, where essentially what they're doing is that these kind of like connect study where each and every cell line is being given a unique code, some kind of like genetic. So they are tagging each cell line with a unique genetic code, mixing up all the cells, co-culturing them together, of different tumor types, and then a similar way is being done even for the drugs, and then mathematically the deconvolution or the matching is being performed based on by treating them in a collective way and then following them over a period of time. And then by performing NGS, you deconvolute them before the those cell tags which has been enriched and which has been depleted in response to the changing concentration of the drugs. So yes, there are model systems now available, or more than that, model systems were always there. They are now tags, and there are now methodologies, sophisticated methodologies, which is there, which allows you to specifically address this question. It's purely in the field of laboratory research. And I'd be very happy for specific.
Yeah.
I'd
So,
be happy to do something.
yeah. So one more question. Normally, whenever we get genomic reports, we get VUS with
Yes.
we don't know unknown signals. So if a patient has a VUS, after how many years you are supposed to go back to the database and check whether it has been reclassified as a pathogenic or a benign entity?
So several things kind of began. I mean, there is no defined timeline. It all. In fact, I would rather kind of like the data which would be more convincing is that if there is a clinical reason, and if a clinician thinks that there is adequate reason for follow-up, that a VUS is associated with the disease. I'm not even talking about the informatic analysis, and not even talking about the predictions. In fact, recently we have published in our cancer, which talked about a tool where we take the structure and other things which predicts rare variants, so the tail of the cancer. Essentially, the timeline where a US would be kind of like set aside and one specific period of time that they become significant. So there's no defined timeline. Rather, I personally believe that if you, as a clinician, think that this may be of a relevant, this is the relevant gene of interest which is associated with cancer, I would go into there and then I would go into the germline sequence of that patient in that family, and I would try and see the association with the other siblings in the family and if the gene, rather than banking on whether that US has that physiologically significant alteration or not. The pedigree information will be far more informative for you to make that call. Whether over a period of time it will become significant or not, or what number of studies will allow it to make it significant, that I do not have a very specific answer to it, because that varies from gene to gene, and frequency of those alterations that occurs in population.
Okay, if there are, actually we are hard pressed for time. One quick question, perhaps. Come. No, there are more questions. I mean, just that, we are hard pressed for time. But please come. One quick question.
Sir, great talk. The question I have is more of a technical question. So, sir, when we do basic research in the lab, we usually go for research, use only reagents, right? But then when we have to develop technology out of it, we have to go for IVDs and then do the clinical trial and, assess the efficacy. So, sir, in your experience, what is the variability that we should expect when we change from RUO to IVD? So, what should we account for while developing a test?
So as what I mean, that's what I kind of like just glossed over. So that was a slide that I had taken from the internet. To bring it on like individual device forming and to get the compliance or FT or any of those agency of the time is something which is a ballpark, which is beyond what a basic scientist or even a clinician would be able to better. So um, uh, this is a zone where my expertise is significantly short. I'm more, that's how I start. I'm more interested in publications, what excites me more. A clinician is more interested in something which is publication is of second related to something that really benefits the patients or not. So my answer is, short answer is that this can only happen repeating through the words and reiterating what Dr. Buddha has already said, is that this can only happen when people like him, the most important person in this case would get more and more interested and come and work around with the clinicians and with the basic scientists as what we have done for the possibility if that can be done more so that take things into the IVDs and have the clinical validations program. I do not have a very specific answer to this, so but like just giving broad thought.
Thank you very much, Amit, for this very informative talk, and the discussions were.
My pleasure. Thank you.
Yeah, the discussions were very, very interactive. Thank you, Amit. Thank you very much. Okay. So moving on, our next speaker for the day is Dr. Vijay Patil. Once again, another great friend of mine. And today I think is the day of people of exodus. Where people working in TMC have left TMC and settled elsewhere and doing well. That was the case with Dr. Amit Dutt. That's the case with Dr. Vijay Patil as well. He was a professor of medical oncology at Tata Hospital till very recently, before he moved to Hinduja Hospital here in Mumbai. Once again, a prolific researcher and a publisher, and and he was instrumental in several practice-changing trials that were published in top journals like Lancet Oncology and JCO and so on. So it gives me great pleasure to invite Dr. Vijay Patil to deliver his talk on generating real-world evidence, and I think that is the most important thing these days. In the sense, how to go about generating real-world evidence, and I'm sure there is no better speaker to deliver this talk than Dr. Patil himself. So Vijay, over to you. Water bottle.
So hello. Did you have a tea break before this? Okay, good. How many of you are medical oncologists? Never raise a hand. So, how many radiation oncologists? Surgical? Okay. And those who are from lab background? Okay, so we have a good mix of crowd here, and so I will be discussing with that respect itself. So now, when we say real world evidence, and one of the fantastic remarks which was made by Dr. Dutt was a scientist, the lab scientist, is interested in publication. A clinician scientist, for you to become a good clinician scientist, publication has to be secondary. Publication should not matter to you. What should be mattering to you is does it benefit your patient or it does not benefit your patient. Now, whenever we say real world evidence, we can talk about retrospective analysis, we can talk about prospective analysis, we can talk about randomized study. Now, mainly people say that, okay, I am a good clinician, I don't do research. Whenever I hear that, I come to understand that if you don't do research, you actually are not bothered about your patient. I'll give you an example. Let's say that you have a practice and you may be a surgeon, a radiation, or a medical oncologist. You do breast cancer. And you have treated up till now some, let's say, 300, 400 breast cancers. Are you sure that their outcomes are same as global standards? Are you sure that their adverse events rates are same as global standards? And how could you be sure that their compliance is the same as global standards? No, you cannot be sure. Whenever I ask my colleagues, even I think they should be. You think. You don't know. You can know only when you go and do an audit. Only when you do an audit, you will see, okay, your outcomes may be same, they cannot be better. Okay, clinical trials have so many scrutinized patients, so many scrutinized, your real world evidence cannot match a clinical trial. If they are better than that, then it should actually spark in you that why are your patients doing even better than the real world? Is there some genetic difference or biological difference? And that props to your question. If they're worse than that, then again it should prop. Was it because of compliance? Was it because of adverse events? Was it, oh, compliance was good, adverse events were good, my dose intensity was good, My surgery was perfect, my radiation dose delivery was perfect, my dose volume histograms were perfect, then why is this happening? Is this because of some biology? Unless you do an audit, you're never going to know what is so-called lacunae. And these lacunae, when you try to fulfill, this can be any question. This can be question like, okay, my head and neck cancer patients, when I'm doing radiation, are getting too much side effects. Then you try to find out why you are getting side effects. You intervene so that the side effects don't happen, and then again you re-audit the results to see that, okay, this has been overcome. When you do that kind of practice, you are not only a good clinician, you are a clinician scientist, where you audit, re-audit. So don't be under that impression that just because you're in private practice, it's your basic job to audit and re-audit your data so that you know that what you're doing is in accordance with the standards. With that, I will just show you what few works which we done and how real world evidence comes into picture. Now, those of you who are from lab background, medical, radiation and surgical will definitely know this. This is one of the prominent studies which was done in head and neck cancers, which is looking at chemotherapy plus targeted therapy like cetuximab versus chemotherapy with immunotherapy. What it showed was that giving immunotherapy led to a lot of benefit, and this benefit was substantial. Now the problem in India is this: head and neck cancer happens in poor socioeconomic conditions. Forget about immunotherapy. Even access to targeted therapy is below 1%. Affordability is a problem. Patients even cannot afford chemotherapy. Most of the patients from point of view of head and neck cancer, because they are tobacco chewers, they are from the rural place, they cannot even travel. Now, is this something which I just came to know because I thought it was? No. This is exactly what I was telling you. till you want to take chemotherapy for symptom relief or you want both. The interesting thing part was, and we never thought that, we always thought that patient would go for symptom relief. 76% of the patient wanted the life expectancy to be increased even if it is those minimal numbers. Many times we start thinking for 1 or 2 months benefit, the patient may not be wanting to take it. But when you ask the patient, and this study was more or less done on the general side of the Tata hospital, only 10 patients were private side. So this actually is for the low socio-economic condition patients who may not have those many resources, but understand that the aim to live long is very strong. Now, we go shift back to another story. So when we saw in Tata that many patients cannot afford targeted therapy, immunotherapy, at that time, uh, if you know, the Maharashtra has a coastal region that's called the Konkan region. And Tata had a outreach project there in Derwan. We used to go there and give free chemotherapies to the patients there. And head and neck cancer and esophageal cancer is very common there. You would be surprised, patient never used to come even for the free chemotherapy sessions. The reason was they were all manual laborers. If they don't work, they don't earn. And they were the only breadwinners for the family. So if you give them IV chemotherapy, they cannot take the therapy on that day. They cannot take it for next 5-7 days. They couldn't come. And this was a big logistic problem that they won't be able to come. So what would you do? We made something called as oral metronomic chemotherapy, which were tablet chemotherapies. And the idea was, okay, the patient cannot take chemotherapy, let him take something which might give him some relief. And so we started. What we saw was in that rural project that it somehow did much better than our expectations. And hence we did this small pilot study. This was published in 2012, in 2010, trying to see with a retrospective analysis whether the patients are actually benefiting. Many times you think clinically they are benefiting, but you remember those patients which have large tumors which come with you. You don't forget the next 15 patients who may not have that reduction, or they may not have come to you because they died at home. So what we saw was, oh, it actually showed some benefit, but number was small. Then we did another retrospective analysis with a larger number to confirm whether this benefit actually exists. It also confirmed that benefit actually existed. Then we actually thought, okay, if the benefit is existing, let us see in front of IV chemotherapy, how would oral chemotherapy perform? Side effects are less, very good, but is the efficacy same or a bit less? And can we replace IV with the oral therapy, which would be much easier for the patient? They won't have to do many hospital visits. So they would spend the time in much better quality of life at the home itself. And what we saw is not only it had less side effect, it was also better. Now this was a phase 2. So we got an idea they couldn't afford. We gave it in a rural outreach product. We saw that it was not benefiting. It was benefiting. We did a small retrospective to confirm that there was a benefit. Did a large retrospective again to confirm that benefit really existed. Then we did a phase 2 to confirm that, okay, it is actually beneficial. Then we actually did a phase 3. Upfront metastatic, correct, yes. And then we actually did a phase 3 of 442 patients, and this was presented in ASCO by my colleague Dr. Nandini. And what it showed was, it actually reconfirmed that oral was actually better than IV chemotherapy. And this came with a better quality of life, better side effect profile, and obviously the cost was also lower. Now, the question is, this is the way your real world evidence you can use step by step. This is one process, this went over 10 years, step by step, for you to actually make an impact. Okay, but somewhere down the line, the start has to happen. And for the start to happen, you need the first data. You need to know your lacunae. If we won't have known, and then that outreach project, that 90% of the patients are not coming for chemotherapy in spite of giving A, the whole process won't have started. So your question can lead you to different directions. This data, when I was in the phase 2 actually, when I was presenting at ASCO, and it was quite appreciated, but there was a lady from France and I could never forget her, and she blasted me right and left on the podium itself. Her question was, you are giving some new therapy, you don't have a basic model to say, you said metronomic. He may say a dose of 10 mg of endoxin is metronomic. He may say a dose of 5 mg of is metronomic. Guy in blue shirt might say 1 mg is metronomic. How do you say that this is metronomic? How do you get to this model? And she said, now it is your responsibility that you saw that it is useful, that you need to give such a model. The problem is, in medicine, all models which have been made up till now are to increase the dose. We keep increasing the dose, we'll keep looking at side effects. Here, we were actually talking about decreasing the dose, de-escalation. So the question was, how do you make this model? And at that time, another exodus from Tata, Dr. Atanu Bhattacharya, fantastic statistician. He's an authority in Bayesian statistics. And we had this discussion, can we make some model? And this was another first model which was been made. This was a statistical model which was been made. We called that optimal biological dose. I mean, this is the dose at which the drug would have metronomic action. And the question was, how do you find the dose for which there is a metronomic action? So after a lot of unsuccessful statistical models, after a lot of discussion with our scientists, we came up with this. The idea is very simple. In metronomic, the target is angiogenesis. Now, how does angiogenesis happen for a tumor? The angiogenesis for a tumor happens when the new vessels start sprouting. Then the question comes, how does the sprouting happen? The sprouting happens because there's a cell called a tip cell which actually destroys the collagen and starts growing. And the question happens, from where does the tip cells come? The tip cell actually comes from the bone marrow. Then it is called circulating endothelial cells or circulating endothelial progenitor cells. So it travels from the bone marrow, becomes a tip cell, destroys the vessel and makes it. So we went across and we saw that there was a good relevance in anti-angiogenic drugs, that if the circulating endothelial cell levels or the circulating progenitor endothelial cell levels go down, the drug has a good anti-angiogenic action. So we said, okay, metronomic, our hypothesis is that it is anti-angiogenic. There is some data to say that it is anti-angiogenic. We would keep de-escalating the dose to see. So at a dose, which is the maximum tolerable dose, which is the dose at which you give chemo, this action does not happen. Hypothetically, when you keep decreasing the dose, at some dose, this anti-angiogenic action would start happening. At some dose, this would actually peak. And a dose below that, this would actually decrease. Now, this was the hypothesis. And this is how previous studies had shown something. Our idea was, how do you get this dose? Now, to get this dose, we actually started making a model. So we decided we will do endothelial cell levels before giving the chemotherapy, metronomic, at day 8. Because we saw that these actions happen within first week. And we would see the decline in the endothelial cells. And greater the delta, greater would be the anti-angiogenic action. The problem was, as clinicians, we are always excited to see response. So I said, okay, this would be one part. If I see that there is good response, I would take that dose. So after a lot of discussion and compromise, it was come that, okay, we would de-escalate the patients. We would see at the response has to increase. At any time we see at 2 dose level, the response is the same, we would go to the anti-angiogenic model as a tiebreaker. And this was the whole model which was made. Now what we saw was responses like this. Understand, all of these patients in this phase 1 were platinum refractory, which means they had received cisplatin and they had failed within 6 months of cisplatin. If you don't treat this patient, their lifespan is below 90 months Even if you give immunotherapy, the response rate is 13%, 1-3, which means only 13% respond. So out of 10, only one patient responds. We saw a response rate of 43% in these patients. And this was the kind of responses you could see. The photo is of a gentleman with a large parasternal nodule. He was a buccal mucosa and going down. Now, this actually gave it a median survival of around 8 months, which was actually good with respect to platinum refractory patients and all oral cavity. And the quality of life of the patient also. Now, but the problem is, this work is not happy. 5% of the patients were only doing well. In most of the patients, the disease had come back. The question was, why did it come back? It developed resistance. This was the time when immunotherapy had started taking a lot of impetus. What we saw, and this is not what was done in our work, after that Dr. Kota has actually done a work on low dose nivolumab and full dose nivolumab, and we had similar results, is that the target in immunotherapy is the T cell. Now the T cell has a receptor called PD-1. This receptor has to be saturated by immunotherapy for the T cell to become functional. You don't have to saturate 100% receptor. A saturation of 70% is good enough. What we saw was the saturation of 70%. Sorry, how do I go back? The saturation of 70% actually happened at a low dose of 0.3 milligrams per kg. After that, if you see the graph, you increase the dose, you don't actually get too many much high saturation. Now the question was, if you go by 0.3 milligram per kg, assuming an average Indian weight of 60 kgs, you require a dose of only 18 mg. The vial was of 40 mg, so I decided a dose of 20 mg should be sufficient. The vial used to come costly at that time. It used to be around 1 lakh at that time, 40 mg vial. So my plan was to split the vial between two patients. So then we decided, okay, let me give low dose nivolumab to a few patients in retrospective setting and see whether it benefits. Now what we saw was it actually had a benefit. Now the next question was, why would it have a benefit in oral cavity cancers? This data is still unpublished. And what we saw was tobacco associated oral cavity cancers, 87% have PD-L1 expression. So the high amount of patients in India who use tobacco, which is, if you see 100 head and neck cancers, 98, 97 have a tobacco use. Okay, especially oral cavity. If you go to oropharynx, you have 17% which are HPV related in India. But then we said, okay, no, we should try immunotherapy. Now the issue was we could have added a full dose of immunotherapy to metronomic. Then it would have actually boiled down to the first slide itself, that accessibility won't have been there. The whole idea was to make it accessible, because we know that it couldn't solve a problem. Okay, and the idea of the whole research, as I told you, when you are a clinician, you want to practice this on the next Monday morning if it is successful. If your idea is not to practice
So next Monday morning, then you are not actually thinking in the benefit of your patients.
Then we actually wrote the study in which we said, okay, we will give metronomic chemotherapy in one arm and metronomic plus nivolumab in another arm. And what we saw were results like this, where patients had a remarkable decrease. In fact, so much so this was
Inoperable patients would actually become operable. Now,
what this shows you is, again, if you have the data with you, the lacunae is with you, you can keep adding one after another, one after another. See, understand, the day when you think you have achieved everything, that is the day when your downfall starts. So you have to keep, see, unless cancer becomes 100% curable, there cannot be 100% because persons have to die. So unless cancer patients have survival, which is
similar to the general population, let's say that you are going to scientific, your job is not done. The way your job has been done, that your patients are surviving the same as
diabetic patient or hypertensive patients, your job will start to make the treatment more side effect less and improve quality of life.
The more you make it side effect less and improve quality of life, your job will be to make the
treatment more convenient. Then your job will be to make it more and more convenient, that one shots and it is not required. Okay, something of that. So don't think that you are going to achieve things. Okay, and don't ever think that what you have achieved won't be surplus. The beauty of research is there will be someone who will be standing here would be much better than me and would do better job, and your job is like a relay racer. Okay, I have achieved this much, I'm passing this baton to you, you go ahead. And all this, when you are clinicians, is for betterment of the patient. That should be your central point. I don't know whether you have a lecture from Dr. Banauli here, but he is my teacher. He's the director of academics in Tata Memorial Hospital, and he always used to tell us that if you do with the faith that this is going to benefit your patient, success will come. And that should be the only thing in your mind when you're doing this research. And even if you fail, it is okay. You know that, okay, this is not the way you have to take, change your way. Now, after that, we actually did a multi-centric trial, and Dr. Rushabh actually presented this in ASCO last year to say that these results can be applied across India. Now, another thing, palliative care. Very simple.
intervention. We actually saw whether it benefits our patients. We went ahead. Once we established this in the
palliative setting,
we actually did a lot of trials in this setting to see whether we could
get it into adjuvant setting. So now we moved from the space of palliative to adjuvant. It actually has failed in adjuvant setting in most of the features. Now, this is my new research facility where we do a lot of work. And this year, we're actually going to present a ASCO oral. And this is a very fantastic, easy study which you could have easily thought about. What you do when the patient has a poor performance status, PS3, PS4, you send them home. You're supposed to send them home. Metronomic, we saw that the side effects are less. Simple study, 2:1 randomization. You tell patient, okay, those who run in best ability, go to palliative care, go home. And you have the number of the patient to see his survival. In the other arm, you tell the patient, okay, these are the medicines, you take it for 7 days. If you benefit, you come back again. If you don't benefit, you don't come back. You stay home. And this is a randomized study then. The results are under embargo. You would come to know the results. I think ASCO will release the results on 15th of May. Okay, but you can understand if it got selected for oral, there would be something about it. Okay, so what did that? Simple intervention. PS2, PS3, there was no treatment for poor performance status. You made a treatment. In India, if you actually do the PS properly, 20% of the patients would come in a condition in which they cannot be given any therapy. Now, CAR-T is another thing. It is very costly. At present, we are developing gamma delta T cells for solid tumors and lymphomas. Our idea, already with the help of Rahul Puraval from ImmunoAct, we have got the cost down to 50 to 60 lakhs for CAR-T, which was around 6.5 CR. This is the team, and we are trying to get this whole cost down and make CAR-T development in 10 solid tumors. And I hope the results will be out by 2026 if we are successful or not. And if successful, we would have CAR-Ts which the cost would be. I always look at what the patient is going to get. So don't mind me, I always do the commercials first, how it would come for the patient. Because if the cost is going to escalate to 2 CR, there is no point in doing that research, according to me. It would be around 20 lakhs. And I'm very sure with more and more research going on, it will come down to some like 3 lakhs or 4 lakhs. A lot of work which I showed was done in Tata, and this was the Tata head and neck DMG at that point of time. And I need to thank my mentor, Dr. Kumar Prabhash, without whom I won't be standing today here. Dr. Vanita Narona, my mentor, and Dr. Amit Joshi, and the whole team of coordinators, the whole team of coordinators who has worked with us on it, and a whole team of residents who was there with me, and you would see all of them names in this publication, who you could see that it is night, and those who have worked with me know that all the data entry happens at night. In a research institute or in a commercial, if you want to do research, forget, you cannot do it in 9 to 5. That's the third and the most important you take on that. If you want to do research, you have to wait after 5 o'clock. You have to spend nights at your centers. You have to spend your Saturdays and Sundays. And if you like your patients, you would do that at least sometimes in your life. Thank you. If anyone has question, you can ask. Bolo Anwar sir.
was the option for maintenance therapy, especially in ovarian cancer? Well, metronomic therapy works.
So there was a study which was done by Sudeep sir, and it was the thesis of Gautam Goyal, in which endoxin and etoposide was tried as a maintenance metronomic chemotherapy. The thing was, it actually led to a lot more side effects than what bevacizumab could leave, and that's why that development never took forward. See, the issue, Anwal Sen, is when we say metronomic, metronomic is like a general term like Indians. You would have Tamilians, Bengalis, Odia, Maharashtrians. What we must understand is just because etoposide and endoxin failed, we shouldn't have stopped the development. We should have searched for some other molecule. See, and metronomic dose like olaparib is a fantastic maintenance, but you know that 40% patients can't tolerate it. You can even try 150 mg olaparib and look at it how it works. You might see that it works differently, might have a better tolerance also. So the idea, and that is the exact reason why I was asking Dr. Dutt. For head and neck, I actually keep searching for head and neck and CNS Nature publications and okay, what can be used for e-purpose, what can be used for e-purpose, what can be, and there is a database called Redo Project. Redo, and it's by Marc Boucher and its team from France. If you go to Redo Project website now, you would get a list of around at least 200 plus molecules which have data which can give you an idea in which cancer a non-cancer drug can be useful. But you have to go step by step. You cannot expect a phase 3 coming next year. You need to select a molecule, give it in 15 patients and see how well it does. Or you can use a Simon stage 2 design in which you give it to first 7 to 10 patients, see how much benefit it does. If it benefits, expand the cohort to a phase 2B, see that if there's a benefit. And if it shows a substantial benefit, then take it for a phase 3. The problem where I felt that we made a mistake as a department in many situations is we took many trials to phase 3 before having conclusive evidence in phase 2. At least we should have had an interim phase 2 kind of like the RMAC study. This is a fantastic design which okay, that's not been seen. This study, that one which had cross, this was supposed to be a phase 2 going to a phase 3. Patients who have undergone salvage head and neck cancer surgery and who are not eligible for radiation. You know that 80% of them are going to fail. The surgeon has done a big job. The anesthetist has done his job. Now what to do with this patient? We thought giving metronomic would benefit this patient. So we actually wanted to go for a phase 3 directly. But then what we thought of, okay, it may or may not be safe. You don't know. Let's do a phase 2 going to phase 3. After 105 patients, the DSMB had to stop the study because there were excess deaths in the metronomic arm. Okay, just because something is good in palliative setting, it may not good be in adjuvant setting. So whether, see what I'm trying to tell you is whether you do metronomic, immunotherapy, repurposing, low cost, high cost, everything has to be done scientifically and with patient safety in account. Thankfully, we had a planned phase 2, so we could stop the study. And after that, May CTRT, we actually did and there was one more study by Dr. Vanita Narona, was with esophagus. We actually sent letters to the IEC saying that, see boss, one of the study has shown these things. We want to go and do a planned safety analysis to see whether this has happened. Both the studies had to be stopped because both the study also showed the same trend. So what I'm trying to say is you need to do that small cohort first to see that there is safety, then a phase 2 to get that, okay, it is efficacy, then only jump to a phase 3.
Sir, one more question, sir. Sir, आपने बोला immunotherapy we see low dose it is working. What about antibody drug conjugate, which is the next big thing in oncology?
So I'll tell you, I have not done much of R&D on antibody drug conjugate. I did it on Herceptin. Okay, and let's assuming that TDM1 and HER2 have the basic property to go and attach is because of the trastuzumab component. So ADC component, once you get attachment, they deliver the packet inside. You would be really surprised when you look at the initial development of trastuzumab and look at the phase 1 and the pharmacodynamic data of trastuzumab. We may not have required doses as high as 8 milligram per kg. Doses lower than that maybe have been effective. I had done it because you know that to treat head and neck cancer, salivary gland cancers have a lot of HER2 positive, and one of my patients just couldn't afford it. So I was looking at, okay, is there any rationale for giving? And that time I actually came across. In fact, I wanted to put a project for low dosing of trastuzumab for salivary gland, but it was cut short, thinking that breast people are not thinking of it. Why would a head and neck medical oncologist for salivary gland would think about a low dose trastuzumab project? But if you, I can share those papers with you. I have them in my paper pile library. There is a good rationale that you may not require trastuzumab in the doses which is suggested. And logically, if you don't require trastuzumab in those doses, you don't require TDM1 and even this in those doses. In fact, just taking that point ahead, even in CAR-T, and I was having this discussion in Singapore in Mount Elizabeth 2 weeks back when we were discussing about that project, but I'd shown them my metronomic work. And two of the scientists actually thought that if we make the memory part of the CAR-T strong, we may not have to use such high doses. At present, we give 5 million cells. We may not have to give 5 million cells to the patient, and that may substantially, not substantially, bring down the cost to a limit, because the most of the cost in the CAR-T actually comes for the lenti or adenovirus vector.
Thank you, sir.
No, I have not worked on less dose of cetuximab. The vial of cetuximab, na. See, so vial of the cetuximab which comes, the cost is so huge that even if I had broken it, and there was another reason why I didn't select it cetuximab. The triple metronomic which was made had methotrexate, celecoxib, and erlotinib. Erlotinib was an EGFR inhibitor. So again, and if this is the EGFR molecule, EGFR receptor, and this is the cell membrane, cetuximab acts from the extracellular domain, erlotinib acts from the intracellular domain. So that question, and erlotinib was dead cheap. So I never thought of adding cetuximab in this regime. No, not even in the platinum. So the good thing about triple metronomic is it's very effective in platinum refractory. It is more effective in platinum sensitive. So this is my burning point with ethics. I always have a lot of fight with ethics. Don't be under the impression that TMH ethics is good. Let me tell you frankly. And he has been a secretary of the TMH ethics, he would agree with me. And even on the receiving side of the side also. So no ethics committee is good. Okay, see, ethics committee is a coalition of people. They have their own wisdom and thought. There needs, I completely agree with you. And I have seen this because when we did the CRSF study, we sent it to multiple ethics committees in peripheries. And many of the ethics committees started asking these questions. See, one thing which needs to be there is that there needs to be substantial amount of investment for doing research. The Tata Memorial Hospital gives intramural funding, which makes such research possible. So an institute which wants to do research needs to have some amount of fund kept for intramural research. Your institute needs to take an insurance. Today, if you're going to do an intervention study, it's mandatory for you to have insurance. Like for the Cancer Research Statistics Foundation, you would be surprised, even PGI did not have an insurance. I had to do an insurance for PGI. But when I did the insurance for PGI, I didn't do for that one study. I did it for all studies. It was like some 2 lakh rupees insurance which was done, but it settles the matter. So someone has to actually apply for such funds or actually go and talk to the administration. See, boss, not one, 10, 20. See, we have to do so many research. One insurance subcon broad kind for the can take care of this. So take the insurance on board. That takes care of your compensation. That takes care of your adverse events. And you need to have some amount of funding which is kept for intramural. And if they can't do it, I'll tell you another way. You can have a departmental fund. See, if you are a surgeon, you have good support from the surgical vendors. If you are a medical oncologist, you have fantastic support from the pharma vendors. If you are radiation oncologist, you have fantastic support from variant. Somewhere down the line, you have to say that भाई ये fund आएगा, ये fund सिर्फ research के लिए use होगा, ये fund किसी को conference जाने के लिए नहीं दिया जाएगा, ये fund conference करने के लिए नहीं दिया जाएगा, ये fund सिर्फ research के लिए use होगा. And when you put those foot down and do those things, then you will see that things would be possible. I was at Malabar Cancer Center in Kannur, and the ethics was very similar. We made a fund. I could do in 2 years some 13 projects there. So it is possible, but someone has to really be behind them. परेशान करके छोड़ना है, बता रहा हूँ, परेशान करके छोड़ना पड़ेगा ethics को, तभी करेंगे. और बहुत बार, many times, which this is I've shared with Dr. Kuta, you need to, as a national body also, we need to have some good ethics lecture. Now, on even every time we talk about good ethics, we talk about nahi compensation hi dena, ye dena. No, that is correct. But another part also, if you don't allow research to happen, progress is not going to happen. So there has to be that amount of, yes, trade-off between good research and this. वो होना पड़ेगा, वरना each time we'll have to look at West, and we won't have anything which is quite developed. See, I don't know how many, if you can Google this, there's an institute called Sanyat Sen. Sanyat Sen Institute every year in nasopharynx, in head and neck cancer session. I have never seen a US institute having 2 orals in the same session. Every year they have at least 2 or 3 orals. And I have been seeing this since the last 4 years. And all these orals are in nasopharynx. Yesterday, the ASCO abstracts are out. I just saw how much Sanyat Sen had, and I was a bit shocked. Sanyat Sen has the same number this year in head and neck. They have it in lung cancer also. Now, no one knew, I'm not sure any one of you knew the name of Sanyat Sen Institute. If I say MD Anderson, you might know. Royal Marsden, you might know. You have to work for it, man. You have to work for it. And the administration have to work for it. Research does not come just because of one person. It is a collective effort. It's a team effort.
Thank you, Dr. Patil, for this fantastic lecture on the importance of audit, retrospective chart reviews, which can generate some very valuable data to generate hypotheses for subsequent clinical trials, and also the importance of fighting with the ethics committee. I think that is also kind of an important take-home message here, because not every older people, in this case ethics committee people, are necessarily full of wisdom. Okay, so with that, I think we have to have a change in program. So Dr. Balu's talk was supposed to follow this, but I think we should break for lunch now. And Dr. Balu has graciously agreed to kind of reschedule his talk to 1:30 p.m., which means you have a flat 15 minutes to finish your lunch and get back here for the 1:30 talk. Thank you very much. And for the online audience, we are going to start the talk session once again at 1:30. So you please bear with us and join back at 1:30 p.m. Thank you. Let me make a very quick. I'll tell people to come inside. Yeah. Sit front. Hi everyone. Please get your plates here, and because we're going to start the lecture now. You may continue to have your food. It will be kind of a working lunch. Okay. All right. This is done. So, good afternoon, everyone. Welcome back for the post-lunch session. It gives me great pleasure to introduce Dr. Balakrishna Sasidharan Nair. He is a radiation oncologist at Christian Medical College, Vellore. He's a professor of radiation oncology there. Besides radiation oncology, Dr. Balu also has keen interest in artificial intelligence and machine learning algorithms. He is also a faculty in several workshops of this type, including the Credo workshop, which is very popular among the medical oncologists. So, with great happiness, I would like to invite Dr. Balu to deliver this talk on study designs and methodology. Please be assured that this is going to be a very important talk because it is going to kind of lead into the protocol development sessions of the afternoon, where you will be writing the section on research methods. I hope all of you will listen to this talk very attentively, despite the lunch break that it is. Thank you.
Thank you, Vikram. It's a pleasure being here. I mean, this is my fourth consecutive year in ASPIRE, and it's been a privilege to train all of you in future for research. So my job here is to talk to you about methodology, and I have varied interests in research. I work with mice models. I have an AI lab. I have multiple clinical trials running. I worked on genomics also. So it's the mix of everything. So I am actually here to talk to you about the practical aspects of doing a research and what should go into a protocol writing. So the focus of this talk is how to write your proposal for a future research that you plan to carry out. Not a protocol which is going to sit very impressively in your computer, but something which you have to do it on the ground. So also, when you have to do that, you have to convince many other people. Otherwise, it will not go forward, including your PI, and then from so on, your institution, the funding agency, whatever. So to do that, what are the steps that you need to do? So at this point, we assume that the first day has been useful. You have a question in mind, a question that you desire to answer for your patient's benefit. The hypothesis is very clear, and you know that this study has to be done, and it has to be done by you in your setting. These things, if you are clear, then the next question comes how to do it. Okay, so when we come to how to do it, the question comes, what is the design that you need to do it? So some of it would have been discussed yesterday, and some of you have come up with a design. We would have probably fine-tuned it a bit, changed it a bit, and some of them have been changed totally from one design to another. But in reality, the design depends on the research question, and then it continues. We decide, look at the outcome, the setting, what is the time that you have in your hand to carry out this research? Okay, and what are the resources that you have to carry out the research? What is the team that you are going to do? And ultimately, tomorrow, when you calculate the sample size, again, you go back to the research question. It doesn't end there. It's not put in stone, because if it is not, you are not able to carry out that, then your question has to come back to a modification process. So it's a very iterative process that you come through this multiple times, and finally you end up with the whole proposal or the idea. So don't think that your research question is put in stone. The design is put in stone. When you come to deliverable, I mean action, you may have to change it. So when you put in your design and methods, it has to be very lucid, very clear, because the first and foremost thing that I tell everybody, I'm part of the CMC's ethics committee for the last 4 years. So I have, not only by doing trials, I read research proposals from various people, not only from oncology, at least 30 in a month for the last 4 years. So I know where the deficiencies come when you write this research. It's about expressing your idea into paper so that the next person is convinced. And that next person will never be an oncologist. And in CMC also, the oncology trials are not given to an oncology reviewer. I don't get it. If they have, the other reviewers have doubts, they will ask me, but it will go to another person. And there people do argue with us saying that, okay, you don't understand what we have written. If you had been a cardiologist, you would have understood this. But then our answer is it's your responsibility to make the other person understand, because once you step down to the reviewer, the next level is you have to convince a participant in your research, isn't it? Which is a patient. If you can't convince a doctor from another specialty, then how will you convince the patient in a layman language? So that skill has to be there to write it in a way that somebody else understands who's not from your specialty, and also anticipating all possibilities. Anticipate whatever that can happen to your patient in your research. For example, yesterday we were discussing that breast trial. We had this introduction of radiotherapy upfront with paclitaxel in TNBC. Okay, and then my question was, how are you going to address the axilla? Then we all discussed that, okay, axilla need not be addressed because it's full clearance. But the anticipated possibility is that there is one patient who might have an extracapsular extension or an inadequate axillary dissection. So what are you going to do with that? You will not run a trial without having a plan for that. So that's what you have to do today, that when you look at writing down your methods, you have to actually look at all the anticipated possibilities that a patient in your trial will take, including death. What will happen? And if death happens, what am I going to do? So that is what a methodology should have. And that overall picture should have from the PI should have. You should not be on the feet thinking when it happens in the trial. Oh, this has happened, what should I do? No, should have a plan. So whenever you write any part of your methodology, 3 things have to be in your mind. One is the objectives, which probably we are kind of finalizing today. And these objectives, in what timeline are you going to achieve, and in what setting are you going to achieve? So when a reviewer is reading, he is actually looking at whether the PI has an idea where he's doing this trial, what resources he has, whether he is able to carry out his objectives in that. So whenever you write something, it has to be in relevance to these 3 points. Okay, somebody else, a multicentric trial can achieve a lot of things. But in India, when at your level, when you're an oncologist who's starting off, you should know our limitations, our resources, and then you should be writing your methods as per. You can write fantastic triple-blinded placebo-controlled trial. Okay, but when it comes to operationalizing even a single placebo, it is very, very, very difficult. It can be done, but you are a part-time researcher, isn't it? None of us are full-time researchers. We are going to be clinician researchers. So 80 to 90% of our time is spent in taking care of patients, and the rest of the time, 10% from your clinics and 50% from your family, you are actually putting into this research. So if you make it too complicated, it is actually going to sit in your computer or maximum reach the ethics committee, and it's not going to go beyond that. So your methods have to be practical and has to be deliverable. For that, keeping context of these 3 things is very important. Okay, so when I talk about study design and methods, I will talk about these 5 categories, of which I'm only going to talk to you about 3 things. The essential elements that somebody will look for, what you have thought of when you design a study. So I'll talk about interventional, I'll talk about observational and diagnostic tests. So when it comes to interventional studies, what is that center stage? Center stage is that thing that you're going to do new to a patient, which I call it here the exposure. That is what the center stage of an interventional design is. The rest of it is around it. Okay, so if you're introducing a new drug, that new drug is the center stage. And if you're introducing a new radiotherapy protocol, that is what we are actually experimenting. So interventional design is built around that particular exposure that you're going to test here. Okay, so when you write about this exposure, the essential elements that have to come, whom are you going to expose to? That is the inclusion and the exclusion criteria. one of the common things, I will not go into deep of each things, but I will tell you what are the common mistakes that we make, is you make the inclusion so strict that you will get some 10, 20 patients, then you will say, okay, we will take off this inclusion because anyway, this is my thesis. That never happened. That is not ethical. So you have to, what I will do if I am looking at inclusion is, I will look at the last 20 patients treated similar in my clinic, and can they be part of my trial? If they can be part of the trial, make your inclusion such that they include them. So if you say patients with hypertension, diabetes, all those are excluded, who will come to your trial? Okay. And even if they come to your trial, when you bring the trial to the clinic, who will take those drugs? You cannot take them. No. So being pragmatic, though there are a specific set called pragmatic clinical trials, which keep the inclusion a little open, you should be thinking of that at your level, where you are generating a new evidence. You don't really need to have a trial which is practice changing, Lancet publication level 3. That's not the idea here. Today, we are actually trying to initiate that research in you, which you are going to conduct, not your dream. The dream will come, as Vijay said, it takes multiple years. It's not this one single trial. This is just the stepping stone. So we want you to write the methods for that, which you will actually carry out. For that, keep it more pragmatic. That's very important. And you have to, when it comes to interventional design, the first thing that a reviewer will look at is, do you know what your intervention agent is? Have you defined it properly? Definition means people will say low dose nivolumab or no dose. What is this low dose? Have you defined low dose? When the previous talk, we spoke about metronomic. That was a very relevant question, isn't it? What is metronomic? How can you call this metronomic? So you have to be sure whether what you're calling as your intervention agent or the new exposure is clearly defined. When you say about radiotherapy, you should say, I would give 40 gray in 15 fractions, 5 days a week, once a day for 3 weeks. By this technique, using this machine, and these are the immobilize. So you have to define your intervention. Why do you have to do that? Because there is a lot of variability in clinics. Okay, if somebody else have to reproduce your result, they need to know what exactly you did. So that is very important that you define your intervention, and then comes the comparator agent. That not only for intervention, other kinds of designs, not only for RCT, where you have a comparator, you have to do that. So the comparison population, what are you going to do to them? The standard of care, that has to be defined, because you are going to do it in a controlled population. So how are you going to control it? So then that's the next thing that you have to clearly write down. You don't have to write down in very elaborate manner. Go back to what you do in clinic. Say that if it is triple negative breast cancer, people with triple negative locally advanced breast cancer who are non-metastatic. When you say that, what are the baseline investigations that is standard that you have used to define this biopsies? Whatever the immunohistochemistry or whatever you have done. So you have defined that. With that, these patients, I would do these many cycles of chemo over a period of this many months, and then I will do this radiation, and that is how it is. And the follow-up is also defined. So that becomes your comparator agent, okay, in the context of a chemotherapy trial. Then comes to the specific elements that we look for in a randomized control trial. This was explained in detail in the previous 2 talks back by Dr. Xavier. But when you say, I would randomize the patient, we expect you to tell us in the methods, how did you randomize? Okay, so there are various methods of randomization. So, sorry, did I jump? This is going back. Okay, so many people will do that, but many people fail to tell us what point of time are you randomizing. Okay, so that is very important. Okay, after the patient has been diagnosed and brought for chemotherapy, before the first cycle of chemotherapy, I would randomize the patient. Fair enough. Okay, there is another question of consenting, which comes prior to randomization. That also comes similar. Maybe I'll talk about it now. Before randomizing comes the consenting of the patient. Consenting is also very important. When do you take the consent of the patient? So the patient has come ready for chemotherapy, day 1. You want to do this trial where you want to intensify the dose of chemotherapy. Patient has brought all his support people, everyone, and then that day is gone to the temple, prayed, and then come. Now you are saying that you want to start this chemotherapy in this trial. You are his doctor. What do you think will happen? No, you have seen the patient. All the while you've been seeing the patient, you discussed the chemotherapy, everything. Your team has discussed, now you told on 15th of May, you are coming for chemotherapy. This is your first cycle chemotherapy. Patient has arranged everything, resources, money. He's taken leave from the office. He's gone to the temple in the morning, come, started for chemotherapy, lie down in the couch. Now you want to include him into the trial. You are approaching him with the information sheet, beautifully explain the information. Is there a problem? Think of a layman. Okay, similar situation I will tell you, non-oncology. There was a radiologist who wanted to actually do a vaginal gel for MRI in cervical cancer. And the radiology doesn't see patients, no? So we asked them, when are you going to take consent? So they said, okay, patient will come for MRI, that day I will do. So MRI dates are actually prior given and the patient has come. So what happens if the patient doesn't consent? Naturally, you will do it, but what is in patient's mind? What is in patient's mind? For the last 2 weeks, I've been talking to this doctor. This doctor is so benevolent, he has taken care of me, he is going to give me chemo. Now, how will I say no? Isn't it? Is that ethical? So, randomization and consenting should happen a little earlier. Okay, maybe it should have happened in your clinic before they have been brought for therapy. So if you had thought of this and put in your methodology, the ethics reviewer would be happier. Many a times, the surgeons take consent on the table. That's a reality. We all write all this, but sometimes they take consent on the table. Put yourself in a patient point of view. I was admitted for, when we had this COVID, mandatory admission for everyone. That was in Tamil Nadu. So I was positive, asymptomatic. Me and my daughter, wife was negative. So we both had to be in the hospital. So CMC is a big research hospital. So as we get in the counter, the admission people, they also gave 5 forms, consent forms. So I am part of the ethics committee. So I know things, how it has to be. So the rest of them are all signing it as they walk in, isn't it? The consent for using my data. But is that right? But practically, that's what we can do as researchers in India. But is that right? Everyone would give consent. Do you have time to think? If I say no to that signature, I said no to that signature, 10 phone calls went up. My admission was delayed by 2 hours. See, should I have taken that hassle? So I'm just asking this question so that you think from the patient point of view also, randomization. You can also think of randomizing patients. There are issues when you do cancer studies. Earlier we spoke about one study where you had nothing in one arm and intervention in the other arm. So when you are randomizing a patient or talking to a patient, you're actually telling them, see, you have this disease. At this point, there is no major therapy, but they have come to you to actually seek therapy. But I have this clinical trial. On one side, I'm going to do 5 cycles of chemotherapy for the next 3 months. On the other side, I will give you nothing. I will just see you and say hi every week or whatever, but I will measure and take data. So, okay, patient will say yes to the trial, thinking that, okay, he will get something. At the end of randomization, you are going to tell them, sorry, you get nothing. Isn't it? So that is one major ethical issue with randomized clinical trials. I am not saying that it is wrong, but think of it from the patient point of view, what they are seeking and what you are giving in a trial. Sometimes it might be, there are modified designs which I have also done, where when there is a substantial investment in intervention on one arm and there is nothing on the other arm, there is a clause where you can do consenting after randomization. That's called Zellen's design. Read about it. I'm just giving you the possibilities. That's not always accepted by ethics committee because the dropout rates can be higher, but that's also one possibility. Okay. So now allocation concealment. All of you would have understood allocation concealment, which was discussed in the morning. Okay, so there are various methods. Simpler methods. Okay, one simple hack I will tell you: use your computer-generated sequence, but don't keep it with you in the drawer. That's what was said in the morning. But keep it with an independent observer somewhere in your hospital. You call them up. Okay, this is my allocation. Can you tell me? This is my patient. Can you tell me the allocation? That's what I generally do, which makes it easier. And non-influenced by the investigator. Okay, blinding and masking, obviously we spoke about it. Always this question comes, I want to do this placebo control trial. You should do placebo control trial. They are the evidence. But remember, adding a placebo means you are adding doubling your cost of your study, isn't it? In many ways. Why? First and foremost, a placebo cannot be something which is inert. Okay, it can be a drug without any particular effect. But what are you masking here? The placebo has to match the other drug. Placebo has to match by taste, color, all those things, depending on what you're masking. There should not be a similar effect. You should have drug control authority approval for the placebo. You should have mechanisms to mask, cover, and give it to the patient. So additional, at your level, are you able to carry it out is the only question I want to ask. Okay, in your study, if you want to give valproate is over the counter or whatever. From the pharmacy, it is given in sealed packets, no need for any approval. You just prescribe, they take it. But what is the methodology you would apply for the placebo? That you have to write it up. Again, when you think of placebo, always remember, if there is an objective outcome that you are measuring, your study is powered for mortality and severe morbidity. Can somebody mask that or fake that? Then what is the need for a masking? So you should always ask, what am I masking for? There is an subjective element like patient reported outcome or a psychological effect, then you should actually add a placebo. But otherwise, you are unnecessarily increasing the overheads of your clinical trial. So be practical. Okay, I think we need to rush. So, okay, this is another quick way to actually impress a reviewer. Okay, to write down the flow chart. It also impresses the reviewer. It also impresses yourself, and it also is a reference guide for yourself, and also a reference guide for your colleague. Every time, please draw the algorithm for your study. Right, draw the picture so that how a patient goes through the trial is very clearly known. Okay, this was my first randomized trial, 2010, and this was the algorithm that was written at that time, which helps you in many ways. Okay, it's very simple. There are various ways you can write this. Sample size, yes, that's part of the methods. We will be discussing in detail tomorrow. We have this policy in CMC, whether most of the time you will say it's a pilot study, no need for sample, or a convenient sample, but in CMC ethics committee, it is mandatory. Whether you select the sample or not, you calculate a sample with a rationale so that you know what is the ideal sample that is required for finding the answer. At the end of it, you can say, because of these reasons, because my thesis is only 2 years, I cannot get that sample, I would take only this, that's fine. But that gives a chance for somebody to actually continue the trial to the desired sample also in future. And you also to know what the limitations are upfront. So always calculate sample. Never settle for convenient sample, never settle for pilot sample. Calculate the sample and then see how it can be made feasible. And also, the sample is always calculated for the primary outcome. So your primary outcome and endpoint has to be very robust and written very well. So that's how it helps the statistician to help you with the sample and the rest of the analysis. There are additional endpoints that you would create. You can power them, but you can also see whether they fit within your sample, which is also some exercise you can take up so that the reviewer knows that, okay, you have actually thought of your secondary endpoints also very well. And the methods for each secondary endpoints also have to be written. It's just not that the primary endpoint and that methods are written. This also has to be written in a trial. Okay, so, yeah, this question, the delta. So many randomized trials, no, you actually say, that's the exercise that will happen tomorrow morning or tomorrow afternoon most happy. What is the difference that you want to find? What is that difference you want to find so that the statistician can, and the discussion goes on around and around with that. So what exactly are they looking for? They're looking for that meaningful difference that you want to see in the clinic with your intervention. So how do you know that, okay, this trial drug causes 30% benefit? How do you decide on the delta? So it can be 5, it can be 10, it can be 15, it can be 20. Where do you put it? Do you put it based on the sample size that you calculate? Many a time we do that. Many a time we find out sample size for 5, 10, 15, 20. Okay, this sample fits me, so my delta is 10. And then you find reasons for that delta. I would say the best way to think is look at the last 10 patients that you have seen in the clinic. In them, you have seen 4 responses out of 10. Okay, now if I am going to intervene in this patient with this kind of therapy, if it's a very simple therapy, even 5 patients getting benefit out of 10 is good. Simple, inexpensive. But if it is a very expensive therapy, you want a larger quantum. A very toxic therapy, you want a larger quantum. So that means 5 patients is not going to cut it for you. It has to be 7 patients. So that is the delta. So now you make it in percentages. Okay, so think small and then bring it into percentages. Then you will get your delta. And that has to be practical. For example, in the STARS trial, which I did, which was a 5-year triple-blind randomized control trial. I'm talking from my mistakes. That's why I give you this example. No, my first trial was a triple-blinded, placebo-controlled, randomized control trial. At the end of 5 years, I had A and B. Nobody knew what A and B is. And I had one paper which I had put up, which is A, which is B. Finally, 5 years down the line, I was searching for that paper. So anyway, so there are a lot of practical issues. In that, I wanted to, the intervention was very, very cumbersome, giving starch to patients daily. And the control arm also given another kind of starch. One is resistant and another is digestible. The fact is, I wanted to actually say that the diarrhea rates, 7 out of 10 patients had diarrhea. I wanted to make it at least 3. And I justified saying that if I'm going to intervene so hard, I need to have substantial benefit. 6 out of 7 patients getting diarrhea is not a good benefit for me to do this intervention for so many people. So that number needed to treat to get that benefit is very important. So think in 10, you will get that answer. Okay, this would be discussed tomorrow, the statistical analysis plan, which you would be writing. I think Dr. Vanitha is talking about it in detail, no? Statistics analysis. Okay, so that would be discussed, that how are you going to take these numbers and what are you going to analyze in future? That has to be written today, not after getting the results. Okay, so you have to write it today, how you're going to analyze it. This one, intention to treat and per protocol, I think that was discussed. In any randomized control trial, you have to define what goes, who is screened, who is included, who has consented and randomized, and finally, how many are you analyzing? So if you are actually taking away the dropouts and then analyzing only the remaining people, then these are patients who have gone through your protocol. That is called a per protocol analysis. A more ethical and a more right way of doing it is to include everyone who has been randomized, which is called the intention to treat analysis. But per protocol has its uses in specific questions, which you will know when the question comes. Okay, this will fit in for this particular question. We don't have to do a full intention to treat analysis, but standard is intention to treat analysis. Budget. Okay, budget is something which we don't discuss much, but from experience, my first trial, budget, I wrote up, I got money. I wrote up for computers, I wrote up for many things. I didn't write up for personnel. So what happens? You have every equipment around you. You don't have anybody to work. You have to work in your clinic. No, I was an assistant professor. I have to take care of my patient and do the trial. So at this point in time, I believe if you are asking for external budget, the one thing that you cannot get from your institution and others is personnel. Invest in personnel. That is how your trials will improve. You will write more trials. So in budget, go for funding that will give you good personnel. A scientist, a PhD, they will write papers for you. So that's the way you should be. Not, of course, you have to look for operational costs. You have to look for equipment. You have to look for patient compensation. All those have to come in the budget, but never forget the actual personnel. Okay. Okay, this is a consort diagram, which is what is written for a randomized control trial. You can generate it online also if you have RCTs. I generally recommend you to actually write the consort upfront itself with your sample size, so that you know how things will happen when the trial finishes. Okay, so expected dropouts and all, you can actually put in a consort and then see. This is the actual consort of the trial, but you can just put it and see. Always good in an interventional trial to include, when you go to the reviewer, include what is the date of your first enrollment, when you expect to start, what is the duration, protocol variations, We don't talk about it much, but it's a bit complicated. Interim analysis and other things. If you have those, please put in your trial, and you should have a defined methodology as to how you are going to do it. What is if a participant withdraws from the trial, what will happen to them? What will you do for them? What happens for premature stoppage? That is, you know what a DSMB is? Everyone knows what a DSMB is? Data safety. What are their roles? What is your relationship with the DSMB? They have to be independent, okay? What is their role? And how do you interact with them? When do you interact with them as a PI? So when you have an SAE, that is a serious adverse event, which you would have defined upfront in your interventional design. If you have a serious adverse event, within 24 hours, a DSMB has to be notified. And it is a responsibility of the DSMB to ascribe the cause of this serious adverse event to your drug or any other event. That's their job. We cannot influence. You provide all the information to them. They will call for meeting. You provide all the papers for the patient to them. They will ascribe the cause of the death. For example, there was this vaccine trial in CMC where we had a crossover between two vaccines, which was done for COVID, actually. And there was one patient who took a vaccine. After 2 weeks, patient took poison, came to emergency. So should we inform the DSMB or not? Yes or no? Yes. How many? No, how many? So how sure are you that this vaccination is not causing him a psychological depression, which is causing suicidal tendency? So these are questions that can be asked. So as an investigator, you be dispassionate about this. Let the DSMB decide what cause has to be ascribed. And they are qualified personnel who can do that. So that is the role of a DSMB. Trial insurance, definitely, as spoken above by Vijay. It's very easy, actually, if the institution takes it. CMC has it, for example, as a blanket insurance for all clinical trials. It's not too much, actually. I think it's around 5 to 10 lakhs for the whole year. An institution pays for all the clinical trials that are done by it. But if you have a pharma-initiated study, the pharma, in the budget, you can actually add the insurance. For institutional trials, you can have a blanket insurance. Post-trial benefits and care. A medical oncologist here? So, okay, what is post-trial benefit and care? I would put it this way. If you have a drug which is working for a patient, which is given randomized and is given that drug, the trial is over. Patient is still, it's a continuing drug. It has to be continued until progression. Patient has not progressed. Once the trial is over, what will you do? You cannot stop it. Okay. The drug has to, as medical oncologists, you will know many patients who are on that, who's just continuing for 10 years also, free drug for an experimental drug at that time, but now it's in the market. Okay, so that is post-trial benefits, and you actually budget for that in pharma trials. Okay. This is a Gantt chart or a timeline. You don't have to do the same thing, but something similar. The timeline of events on your clinical trial has to be put in a picture. This is our methods to impress your reviewer. Okay, I have thought of this timeline, and this is when I would finish, this is when I would publish, this is when I will get the data. If you have that also, you will know whether you are on time or you are actually delayed. Most often we are delayed, but at least make a calendar for yourself. Okay, so essential other things in an interventional design are regulatory issues. So there is, for a drug, you need a new drug, you need a DGCI approval. Repurposing an old drug for a new indication, you need an approval. Okay, so these two situations, you need an approval. GCP certification is usually all PIs should have a good clinical practice certification. Many courses are there. Please take that. Ethical clearance for animal studies, all this have to be done. Insurance, I told you. CTRI, it's a clinical trial. Nowadays, please make sure you register them. You can do that only after your ethics approval, because your ethics document also has to go online. It's an online process. They will send questions and it will take a month to get a CTRA approval. HMSC is Health Ministry Screening Committee approval. This has to be done for any kind of knowledge exchange for research in human subjects at this point with India and any other country member. Okay, need not be if only you get funds. Even if you are having a collaboration, you need an HMSC clearance. That's a new rule as of now. First HMSC clearance, I got it in 9 months. Second one, I knew something, so I took 6 months. Third one, 3 months. Doesn't mean that it's an easy process. There are a list of 14 documents now we have created, which has to be submitted for HMSC. They will send you queries. ICMR coordinates that. MOU is Memorandum of Understanding. Most of you speak of multicentric trials. It's not an easy thing. You should have a Memorandum of Understanding. Material transfer agreement has to be there. If it is not there, you can still do the trial, but if something goes wrong, that's when you get into trouble. So always have all these things ready. Okay, so that is about interventional designs. Most of these elements are same for all other designs also. I'm just talking about in general and then adding certain extra things. So I spoke about exposure as a focus for interventional design. What is a focus for observational design? You're not doing anything to the patient. You're only collecting data. So here your focus on your methods is how are you going to collect data? Which data are you collecting? Where are you sourcing it from? What is the population you are taking this data from? What are the possible variations in this data? So these are the ways you should write the methodology. So source of data, the variables, the confounders, how are you going to reduce bias if you're collecting data? Matching, all those can happen in observational design also. How are you going to match the case and controls? Missing data. So you might have to be looking at things in database. How are you going to handle missing data? Okay. And how qualitative and quantitative variables are handled in an observational design. This is the methodology that I would look for if somebody has written up an observational study design. Also, the sample size here is very important. Statistical analysis plan is also important. Okay. So there are some general questions that come up when we speak about this. When is a study prospective and when is an observational design? When is it prospective and when it is retrospective? Are data collection studies always retrospective? How, give me an example of a prospective data compilation. Okay, so that is prospective observation of a patient. So what about, I've stored some tissue samples of a patient. I'm actually looking for a new mutation in them. Is it prospective or retrospective? Is that question important? Why? It's observational, I agree, but is it prospective? You are generating new data. Obviously, that is prospective, but the sample is already there. So the why is this question important is a question of consenting and ethics. Okay, so if you are doing something new to a human sample, which you have not got consent for, and which has an implication on the patient's future care, you need a consent. Okay, for example, I have stored blood samples of some patients who have come to me, and I am going to do HIV testing on them. Won't it have if I get a positive result, won't it have an issue on their future life? Yes, so I should not be. So if I am going to do a dosimetric analysis on an already treated radiation oncology patient's scans, do I need a consent? I can ask for a consent waiver because treatment is already over. I am only testing on the previous images. So it depends on this consequence. You can ask for a consent waiver to the ethics committee and they will analyze and give you a consent waiver. Okay. So now quickly to diagnostic designs. Diagnostic study designs, for example, I would put the prognostic modeling studies and all are diagnostics because you are actually trying to predict something. Diagnosis also is same thing. You are trying to predict something. So here, the focus is on the test. And when you write the methodology, what we should focus on writing is who are being tested, when are they being tested, how are they being tested. And beyond that, you have to also have an idea of the reference standard. So when you have a test, you are actually comparing it with the standard reference test. What is your reference standard has to be mentioned. Your experimental test has to be clearly written down, the methodology. If it's a lab test, the entire methods have to be written down. Personal training. So if it is a test which is personal skill dependent, how much training you have to do. So that has to be, what kind of personnel are going to do the test? So that has to be defined. Okay, and then the other things are similar to observational designs as to missing data and interpreting results. Okay, so this is something which is usually we look for in a diagnostic study to have your confusion metrics written up, which the statistician will help you. So why we should do that is that if you are doing a test, for example, in oncology, if you're doing a test with which you are going to escalate therapy for a high risk group, okay, you want the test to give you more false positives or false negatives. Which one do you want to minimize? What will have an implication? What will have an, if my test is going to help me de-escalate therapy, what will be more important for me? Okay, think about it. These two are different scenarios when you use the test. So that is why the test, you should know your confusion metrics, whether you are developing a new test, whether it is going to have more false positives or false negatives, how is it going to help you in decision making with your question? That has to be thought of. Okay. So these are some references that you can look at for diagnostic studies. Okay, now ethics. Everyone actually, I'm part of the ethics committee. I'm also a researcher. I also have had fights with the ethics committee, but I believe ethics is your friend, because when everything goes well, ethics is your enemy. But when things go wrong, ethics is going to, IEC is going to take responsibility on your behalf. The institutional head is going to take responsibility on your behalf. I know of big cancer centers which have been brought into the media and all their clinical trials stopped because of one specific patient going wrong. Okay, so your ethics committee has a wisdom to save you for a future anticipated issue. And that's why they are very critical on it. And I feel the more they are critical, the more safe we are in running the trial. More than us, that is about us, more than us, the patients who go through the trial, they have to be safe also. So that is why ethics is very important, and try to be, that is also the reason that your methodology, everything has to be written in a language that everyone understands. Never be ambiguous. Make it simple, make it very clear. Okay, so again, when you include people, the ethics questions that ethics ask and they look for is, do you have the consenting in all languages that the patients are coming in? Whether there is a clear information sheet. Information sheets are supposed to be an invitation for the trial. Okay, some of the information sheet I write is very technical. It has to be an invitation to be part of a research. Patient has to feel he is the primary person invited there. You have to think of vulnerable groups, okay, in your trial. Most oncology trials, I don't think we include pregnant women and all, but when it comes to children, above 7, we are supposed to get an assent as per the rules from the child also, and below 18, all parents also have to give the consent. Okay, so when it comes to children, there is a double documentation there. You have to write in your methods, how are you going to store the data, who all are going to, in any trial, who all are going to have access to it, and how are you going to secure it. So that is data privacy, data confidentiality, and how are you going to anonymize the patients. Okay, later I should not look at, I should not be able to find out which patient is this, which has skewed my this thing. So that actually is not an ethical thing, and patient anonymity has to be ensured. Payments and inducements, yes. There are trials in which you can pay patient for the expenses that they incur, but it should not be an inducement to participate. You should not tell the patient, if you are part of the trial, you will get all the treatment free. Okay, that is an inducement. So that has to be cleverly handled. These are things ethics committee will look at. So budget I already spoke about. I would concentrate on personnel, though other things are also important. Some specific things that we would look for in your thing is not only in methods, we would like to, that's why the format that was given to you, we asked why, what is your background? Why do you want to do this research? That why me question is very important when it comes to writing up this thing. And the significance, risks, you have to look at all the risks that you would anticipate and the deliverables. What are you going to deliver from this research? These are things that you should be writing in your proposal. So I won't go into the examples because there's not much time. So I would stop here and I will take questions if any. Otherwise, we'll discuss in the groups.
Thank you very much. Thank you very much, Balu. So that was a very end-to-end presentation on how to write the method section, including the minutest details. So I don't think he left anything behind. So I think you are now well equipped to develop your protocols. Okay, so I think we have to disperse now, and I have to apologize to Balu because we don't have time for Q&A. And there is a small, announcement that I want to make. This hall has to be vacated by 4:30 p.m. because there is going to be some wedding preparations in this hall. So we have been given time till 4:30. So all of you should be mindful of that fact and make sure that you don't overshoot your timelines time within the group discussions also. Maximum one person can take 10 minutes in which you will propose your methodology and then get feedback from your faculty. So please stick to this timelines. Otherwise, it may so happen that a couple of you may not be able to kind of present your ideas at all. Okay, so but thank you very much, Balu, and definitely Dr. Balu, being the faculty at the workshop, he is available for the next 2 days. So feel free to kind of ask him any questions whenever you need. Okay, and with this, I think we should kind of break out for our protocol development sessions. And as usual, just like yesterday, the first group will be here, second group will be